Good evening all, and welcome to this session of ocular oncology for postgraduates. So right now we are in the session of retinochoroidal tumors. So just a small introduction to the whole meeting. World Cancer Day, which is 4th of February, is a global initiative to raise awareness of cancer and encourage its prevention and detection and treatment. Theme for this year is Close the Care Gap. So this World Cancer Day, Sankara Academy of Vision and Sankara Eye Hospitals have come with this elaborate ocular oncology for postgraduate program under the aegis of Karnataka Ophthalmic Society and Bangalore Ophthalmic Society. We recognize the power of knowledge. We know that every single of us has the ability to make a difference, large or small, and that together we can make a real progress in reducing the global impact of cancer. Let's play our part in creating a cancer-free world. Sit back and enjoy the illuminating talks by our national and international faculty. So I would like to invite my colleague, Dr. Nidhi Jain. She is a consultant vitreoretina and ocular oncology services at Sankara Eye Hospital, Anand, Gujarat. Madam, you can take over.
Thank you, sir. So a very good evening to everyone. I welcome you all to this lecture series on retinochoroidal tumors. This series is a part of the day-long World Cancer Day program, as Dr. Divyansh just elaborated. So this session will mainly focus on retinoblastoma, a childhood tumor, which has good potential for treatment, provided it is diagnosed at the right time and treated appropriately. So without much delay, I'd like to invite our consultant in vitreoretinal services and ocular oncology services at Bangalore, Dr. Divyansh Mishra, to start the talk on retinoblastoma classification. Over to you, sir.
Ma'am, can we start the talk, ma'am?
How are you?
Good evening all. Today my topic of presentation is retinoblastoma and Icrb classification. I'm thankful to be part of this August gathering of ocular oncology. So before direct jumping into the classification, let's discuss regarding the differential diagnosis of retinoblastoma. The most common differential diagnosis is the Coats disease, where retinoblastoma mostly bilateral and Coats is mostly unilateral. Vitreous seeding is more common in retinoblastoma, and the reflex, what we see in cases of retinoblastoma is a white reflex or a cat's eye reflex. But in cases of Coats disease, what we see is a yellow reflex or a xanthochromia. Vascular malformations are more common in cases of Coats disease. Intraretinal or subretinal mass lesions or calcium is more common in retinoblastoma. And in Coats disease, it usually presents as exudative retinal detachment. Clinically, most important is the bending of blood vessel or entering of the blood vessel into the tumor mass, more diagnostic in retinoblastoma. And in Coats, we see vascular malformations and the blood vessels don't enter into the mass lesion. ROP or stage 4, which is retrolental fibroplasia, it presents with history of prematurity, NICU admission, supplemental oxygen, total retinal detachment, and no calcification is seen. Congenital cataract, where antersegment is completely normal, only cataract is seen and there is no mass lesion and no calcification. Familial exudative vitreoretinopathy presents with subretinal hard exudates and fibrous proliferations, fractional retinal detachments. It is mostly bilateral and has family history of sibling affections and maternal screening. Posterior persistent hyperplastic primary vitreous or a PHPV, where a sectoral cataract can be seen and a stalk emanating from that part of the cataract to the disc can be noted. Endogenous endophthalmitis or endophthalmitis, where CCC, complicated cataract, or B-scan showing membranous echoes or some cases of retinal detachment can also be made out. Coloboma, which is usually inferonasal, can be associated with iris colobomas, and otherwise the disc on macula would be normal in these cases. Toxocariasis, where the patient can have a history of PETs, exposure to PETs, and peripheral granulomas and tractional retinal detachment. So once the diagnosis of retinoblastoma is confirmed, it can be classified by utilizing an international classification of retinoblastoma,
Understood, yeah.
which
So,
is provided
okay,
by
I've done it.
Shields et al.
I've done
in
it. I've done it.
2006. ICRB group A means a small lesion which is away from the central areas, and the size is less than 3 mm in basal height or either in thickness. A group B, which is a large bubble where the size of the tumor is more than 3 mm, but it involves the macula, which is less than 3 mm from the fovea, or either juxtapapillary, which is less than 1.5 mm from the disc. And it has subretinal fluid. Mind you, it's only subretinal fluid without seeding, which is less than 3 mm from the margin of the lesion. And if there is a circumscribed seeding and the tumor is large, as we can see over here, there is multiple subretinal and preretinal seedings, which are less than 3 mm. So subretinal or vitreous seeding, or it can be both, comes into group C. And group D, which has a large lesion with diffuse seeding, as what we can see over here and in the video, where a large tumor lesion is there on the nasal side and temporally multiple areas of subretinal seeding can be seen. So it can be either subretinal or vitreous, which is more than 3 mm, or it can be both. Group E, which necessitates enucleation, the first and foremost criteria is a tumor which is filling more than 50% of the globe, which presents as neovascular glaucoma, or where the media opacity is due to vitreous hemorrhage in anterior chamber, or either vitreous or subretinal space. There can be invasion, or the fourth criteria is where the invasion of the posterior laminar optic nerve, choroid, sclera, or sometimes anterior chamber. This is the newer classification which is added to this, where the vitreous can have seeds. There are different types of seeds like clouds, dust formation, or spear, or there can be combination of both. So the take-home message is, most importantly, uniform nomenclature is required for a uniform communication. So there are different classifications if you want to go through that, but most commonly followed is the Icrb. Another which is more closer to it, which was presented in 2005, is International Intraocular Retinoblastoma Classification. Another one which is more prognostic and has a overall association of even heritable trait, that is tumor or lymph node metastasis, and even H means heritable part of it. And there is an extraocular classification where International Retinoblastoma Staging System is also utilized. Thank you.
Thank you, sir, for this precise and clear lecture. I request all the audience to post your questions in the chat box. So we'll be taking the questions at the end of all the lectures. So now moving on, I would now like to introduce our next speaker, Dr. Santosh Honnavar, a stalwart in the field of ocular oncology who doesn't really require any introduction. He is the Director of Medical Services at Center for Sight. He is a part of the Advisory Board of International Council of Ophthalmology, Secretary of the Oculoplastic Association of India, Vice President of the Asia Pacific Society for Ocular Oncology and Pathology, and the Editor-in-Chief of IJO. I invite you, sir, to enlighten us on the various treatment options available for retinoblastoma based on the staging of the disease. Dr. Santosh, sir.
Thank you, Nidhi. Thank you, Divyansh, Mahesh, for this wonderful opportunity. I'll share my screen. And also for allowing me to speak live rather than recorded. All right. So this, of course, Divyansh has covered very beautifully, and this is the basis for my talk. How do we manage retinoblastoma based on the stage? Before we start managing retinoblastoma, we have to have our priorities right. Salvage of life is the first priority, primary priority, followed by salvage of the organ. In our case, it is the eye. And the tertiary priority is salvage of function or optimal residual vision. We have a spectrum of management modalities for retinoblastoma, and what we do is customization based on prognostication and also grouping and staging of the disease. For small tumors in group A and group B, focal therapy is preferred, where our aim is to produce minimal scarring and collateral damage with an aim to provide vision salvage, because we already know that in group A and B tumors, eye salvage and life salvage are granted. So our main aim is now to optimize vision salvage. So basically in such small tumors, we depend on either laser TTT or cryotherapy. Cryotherapy has excellent success, more than 90%, but the size of the scar that is produced is much larger than the tumor that you began with. So it can be a critical factor in deciding on cryotherapy, because it's triple freeze thaw cryotherapy, freezing not just the tumor, but a cuff of vitreous, which is anterior to tumor, also needs to be included in the eye ball. So that's a relatively larger scar, and it is avoidable in patients who have a lesion which is more posterior than the ora serrata, anything towards the equator is generally not preferred to be cryoed, especially on the temporal side. Photocoagulation is mentioned only to be condemned. Of course, it was a very good modality when it came into vogue. It does involve lasering around the tumor, 2 large spot lasers, 2 rows confluent lasers around the tumor, thus producing a much larger scar than the tumor that you began with. And also the issue of vascular occlusion, as you see here. And if the lesion is located in the juxtapapillary area for that matter, then you will have a large visual field defect. You also have the risk of ILM rupture, vitreous formation, and it also reduces chemotherapy uptake. So what is current is transpupillary thermotherapy. Using an indirect ophthalmoscope delivery system, 1300 micron, you can reach anywhere and you can safely laser the lesion right on top of the lesion without having the side effects that you see with laser photocoagulation. You can see nice preservation of the blood vessel that is passing through the tumor, and the scar is never going to be larger than the tumor because you precisely laser right on top of the tumor. This is not exactly photocoagulation, but thermotherapy, where your aim is to raise the intratumoral temperature to about 45 to 65 degrees centigrade so that there is gentle tumor cell apoptosis. That's how the tumor resolves. Now for group B tumors which are more than 3 millimeter size in visually critical location, obviously you cannot use focal therapy. So obviously here the idea is to preserve vision, and especially if there is a tumor which is located in the juxtapapillary area or macular area or foveal area, then you would definitely want to preserve vision. And there comes the role of brachytherapy or chemoreduction. Now, brachytherapy can be used for tumors which are about 16 millimeter in diameter and 8 millimeter thickness in theoretically, and it has 90% success, which is very good. And there are designs of plaque which can fit to a juxtapapillary tumor. This was a patient where chemoreduction was contraindicated because of systemic issues that the child had. So brachytherapy has been performed, but you can see the scar right on the macular area. So this patient, despite brachytherapy, will not have central vision because of the location of the tumor itself. One more tumor where brachytherapy has been performed. If you look at the tumor itself, of course, it is scarred nicely, but if you evaluate the case critically, you can see a lot of RP changes exactly in the same area where the tumor was earlier. So plaque brachytherapy is useful, but may not give good vision. That is the reason why even in group B, in visually crucial locations, we prefer chemotherapy, either intravenous or intra-arterial if patient can afford that. Now, this is a larger tumor and there's one more smaller tumor here. You can see after chemoreduction, the scar is much smaller than the tumor that you began with. That is the beauty of chemoreduction, where the tumor leaves a much smaller scar and also it regresses away from the fovea macula towards its blood supply. So here supratemporal arcade is supplying the tumor. Tumor has regressed away from fovea macula towards its source of blood supply and has resulted in a much smaller scar. Consequently, vision is preserved. So visual preservation is very much possible with chemoreduction. One more similar example of a larger tumor occupying the fovea macula. It has left the fovea macula very early in the course of treatment, thus maximizing vision. So intravenous chemotherapy has been the standard of care in the early 2000s. It shrinks the tumor, tumor regresses towards its source of vascularity away from macular fovea, and exudative retinal detachment settles down very early in the course of treatment. We use a combination of carboplatin, etoposide, and vincristine. What is new is intra-arterial chemotherapy protocol, either with a single drug that is melphalan or with a combination of topotecan and carboplatin along with melphalan. There are 3 drug protocols, there are 2 drug protocols, and a single drug protocol as well. In group B tumors, if we happen to use intra-arterial chemotherapy, you can be assured of excellent success, nearly 100% success. But it is comparable to intravenous chemotherapy. So if you have a compelling reason to use intra-arterial chemotherapy, maybe to avoid systemic side effects, it's good for group B tumors, excellent results. Now in group C and D tumors, systemic therapy is preferred. Here we need to optimize eye and vision salvage. Life salvage is taken for granted in group C, and to a great extent in Group D as well. In Group C tumors, there is focal subretinal seeds or focal vitreous seeds. Here, focal therapy alone has limited role. Brachytherapy alone has limited role. What we depend on typically is chemoreduction, either with intravenous or intraarterial chemotherapy, along with focal therapy. And for the seeds specifically, we use periocular or intravitreal chemotherapy. This is an example of a patient where there are focal vitreous seeds, which have all regressed following systemic chemotherapy. This is a patient, again, with a little larger tumor with focal vitreous seeds, regressed completely with intravenous chemotherapy and periocular chemotherapy during intravenous chemotherapy. So if you have vitreous seeds and a viable retinal tumor, your primary management is going to be chemoreduction, systemic or intraarterial, along with periocular chemotherapy. Once the viable retinal tumor is minimal or has completely regressed, for the residual viable vitreous seeds, you give intravitreal chemotherapy. So idea is not to enter the eye when there is significant amount of residual retinal tumor so that there is no extraocular extension. So the intravitreal chemotherapy can be given with either melphalan or topotecan. Melphalan is very useful, very strong way of giving intravitreal chemotherapy. It's a very nice drug, but it produces side effects such as uveitis, cataract, and also logistically difficult because of the need for weekly injections, multiple injections, and retinal toxicity. Topotecan, whereas, is much gentler, needs spaced out 3 weekly injections. Couple of injections is all that is required, and it is not toxic to the retina, as has been shown in this picture and also by ERG studies. This is one more example of patient with focal vitreous seeds completely resolved after 2 doses of intravitreal topotecan. Now, Group C tumors can also be treated with intraarterial chemotherapy with nearly 100% assured success. In Group D tumors, where there are diffuse subretinal seeds and diffuse vitreous seeds, chemotherapy is the sheet anchor of management, either intravenous or intraarterial. And of course, for seeds, we give periocular or intravitreal. This is an example of a patient with a large tumor with diffuse vitreous seeds managed with intravenous chemotherapy and periocular chemotherapy. These are examples of patients who have been managed with intraarterial chemotherapy. Note that the success of eye salvage reduces to about 90% for Group D tumors, whereas it was 100% for Group B and C. There's one more patient where the residual vitreous seeds have been managed with intravitreal topotecan. Where there are refractory vitreous seeds, we can use a combination of topotecan and melphalan as well. Even for subretinal seeds, earlier we used to laser them very extensively. Now we can use intravitreal topotecan. So larger tumors do have systemic risk factors in the sense that they have clinical risk factors which may be the harbingers of histopathological risk factors. Here, the challenge is to optimize life, eye, and vision salvage. I'm talking about Group E tumors here, which have a risk for life. Here, again, the most important management is chemotherapy, intravenous or intraarterial, along with enucleation, which has to be brought in where indicated, and adjuvant therapy. Now, this is an example of a Group E tumor which has been managed with systemic chemotherapy with good success. One more Group E tumor which has responded very well to systemic chemotherapy. Group E tumors can also be managed with intraarterial chemotherapy and has about 50 to 60% chance of eye salvage. Now, here a patient is a patient with total bullous retinal detachment with a large tumor managed with intraarterial chemotherapy. In patients who have clinical risk factors, but these are just depository anterior chamber seeds, we can give intracameral chemotherapy with topotecan. One more example of a patient with intracameral topotecan with 5 microgram dosage. Now going on to staging. All this was stage 0 because there was no enucleation performed. Now stage 1 is when enucleation is performed and tumor is completely resected. And stage 2 is when enucleation is performed with microscopic residual tumor. So enucleation has to be brought in when a patient has advanced unilateral retinoblastoma with no visual prognosis, retinoblastoma with neovascular glaucoma, and anterior segment infiltration. All these patients who have clinical risk factors are potential candidates for enucleation. When we talk about enucleation, it is with minimal manipulation technique. with a long optic nerve stump. Anything less than 15 millimeter is suboptimal. You can easily get up to 19 to 20 millimeter optic nerve stump by using a good technique. Primary implant is mandatory so that you can provide adequate cosmesis. What is more important than the surgery itself is the pathology. 20 to 30% of children die despite primary enucleation. That's because they have unrecognized histopathological risk factors. Now, what are the recognized histopathological risk factors? Anterior segment invasion with iris and angle infiltration, ciliary body invasion, choroidal invasion more than 3 millimeter in thickness and 3 millimeter in diameter. That's called major choroidal invasion, and optic nerve invasion beyond the lamina cribrosa. If a patient has these risk factors, then following enucleation, we have to provide adjuvant chemotherapy. So histopathology is very important in recognizing the presence of risk factors and also to see if there is microscopic residual tumor. Now, what is microscopic residual tumor? When there is full thickness scleral invasion or extraocular extension, as is evident here, or when the optic nerve cuttend is involved, that's called microscopic residual. And in such patients, we have to give adjuvant radiation as well. Now, the role of this adjuvant therapy is very important because it can reduce the risk of metastasis from about 24% to 4%. Now, what about the next stage? Stage 3 is regional extension, where there is orbital disease, or 3B is regional lymph node involvement. Now, orbital retinoblastoma can be further classified. It can be classified as primary when it is clinically evident or radiologically evident orbital extension. Secondary is following enucleation, the tumor has recurred. Accidental is when somebody has done an intraocular surgery on an unrecognized retinoblastoma. Overt is when you detect it following enucleation. And microscopic is when the pathologist tells you that there is extraocular extension. It used to have high mortality, but the current protocol is multimodal treatment. We begin with high-dose chemotherapy. This is the orbital component. With high-dose chemoreduction or neoadjuvant chemotherapy, orbital component regresses and the eye gets into a comfortable phthisis. That is when we enucleate. Now, this can be used even for optic nerve extension right up to the orbital apex. You can see the optic nerve caliber having returned to normal. The child is ready for enucleation. This is a patient with anterior intracranial extension to the cavernous sinus. Again, treated with neoadjuvant chemotherapy. You can see that the eye has gone into phthisis. Residual tumor is just at the superior orbital fissure, amenable to stereotactic radiation. Of course, all these patients need enucleation. Now, following enucleation, we deliver stereotactic radiation and also give adjuvant chemotherapy. The child gets about 12 cycles of chemotherapy here. You can see this orbital tumor reduced to a nice phthisis, enucleated and fitted with a prosthesis after completion of treatment. So cosmesis is a bonus in multimodal treatment of orbital retinoblastoma. We don't have to do orbital exentration anymore. With all this put together, stage-based management, there is about 95% chance of life salvage and only 5% children. And in our situation, only 3% children died because of tumor itself. Otherwise, there is about 95 to 98% success. Now, where eyes can be salvaged, several of these children continue to have good vision. So in conclusion, I would say that in group A tumors, we have to use focal therapy with visually appropriate focal therapy. In group B tumors, in visually critical location, chemotherapy is the ideal initial treatment. In group C, D, and good E, that is good in the sense there is no clinical risk factor, chemotherapy with local and focal therapy. In group bad E, that is with clinical risk factors, then primary enucleation with histopathology guided adjuvant therapy. In stage 2 retinoblastoma, adjuvant external beam radiation and chemotherapy. Stage 3 is multimodal therapy. And stage 4, where there is hematogenous metastasis or CNS disease, it is either multimodal therapy with very limited success or palliative care. So in conclusion, retinoblastoma management is complex, and we have to stage the disease, group the disease, and provide individualized management by a team approach. Thank you so much.
Thank you, sir, for this wonderful lecture. We surely learned a lot. So Thank you. Now I'd like to introduce our next speaker, Dr. Usha Kim, Madam. She is the Chief of Orbit Oculoplasty and Ocular Oncology Services at Aravind Eye Hospital, Madurai. She is also the President of Oculoplasty Association of India. I invite you, ma'am, to talk about counseling a parent with retinoblastoma.
Thank you, Sankara Academy, especially Dr. Mahesh Sir, Nidhi, and Divyansh. Thank you for giving us this wonderful opportunity. I will be sharing my screen. Is it visible?
Yeah, ma'am.
Yeah, okay. So this far we've been listening to the classification which helped in identification of the lesion as well as putting it in a place where we could treat these patients, and Divyansh did a great job, and Dr. Santosh followed it with a wonderful way of managing the case. But I think we ought to step up a little higher and see how we can prevent it. At this point of time, we cannot prevent the disease, but at least we could scale up in preempting the disease and predicting whether the next child or the offspring would have the disease. So let me start off with a little brief introduction. We all know that retinoblastoma could manifest as a non-heritable entity or a heritable entity. So leaving the non-heritable apart, I would concentrate on the heritable part, which forms a good 40%, wherein it could manifest as a unilateral entity or a bilateral entity. Definitely the bilateral entity forms a larger group, but do remember that a heritable disease can also manifest as a unilateral disease. Now let's look at how it presents itself. Now, we all should understand that one allele in the, so you all understand that it's retinoblastoma is caused by the neural retina specific alteration of the RB1 gene. So it is the RB1 gene that we need to concentrate on. It's a very large gene and a very difficult gene to spell out as well, as far as the genetics is concerned. But we should remember that one allele in the RB1 gene has to be mutated in every cell, and the second mutation occurs in the retinal cell. So one allele has already inherited, and the second mutation would occur in the retinal cell. This is how the inherited RB manifests. Whereas in the non-inherited entity or the sporadic entity, you would have two normal copies in every cell, and one copy gets mutated in the retinal cell. This is how the sporadic entity manifests. So you need to have an inactivation of both alleles in order to have the retinoblastoma manifested. Now let's look at what the heritable does. Now heritable, there is a risk of additional cancers, an increased risk of retinoblastoma in the siblings and the offspring, and these alterations can be identified in the blood, which is a good news for the genetics prediction. Now the non-heritable entity, there is no risk of additional cancers, and there is a reduced risk of the occurrence of retinoblastoma in the siblings and the offsprings, and the alterations are often identified only in the tumor. So the eye has to be enucleated, and we should have access to the tumor tissue in the non-heritable entity. Now let's look at different case scenarios. Here is one little child who had a bilateral retinoblastoma, group E and group C. So it falls under the entity of multifocal retinoblastoma. Now on eliciting the history, the mother had been enucleated way back early in her childhood, and we assume it to be retinoblastoma. So we did an analysis of the blood of the father, mother, and the proband, and fortunately or unfortunately, the mother and the proband had a similar mutation, and so we predicted the risk of the next sibling having the retinoblastoma. So since we had preempted that this next sibling would have a chance of retinoblastoma, we asked the parents to bring the child early. So the child was brought in very early, and fortunately, to our good luck, it was group B retinoblastoma in both the eyes. And when screening the blood of the sibling, we found a similar mutation. So the mother, the proband who presented initially, had a similar mutation. And since we preempted the risk for the next sibling to have a similar retinoblastoma, the sibling was brought in early and was treated, and the patient's, not only the eye, the vision also was salvaged because it was early presentation of the disease. Now let's look at the next individual. This child had a group E retinoblastoma, and there was as usual, we did the analysis of the mother's blood, the father's blood, and the proband's blood, and we found out that the father had a mutation which was very similar to the proband. So the mutation was very identical, but unfortunately or fortunately, the father was an unaffected carrier, which meant that the father did not have the manifestation of the disease in the eye, but was carrying the mutation in his gene. And eventually this child started off as unilateral RB and turned to a bilateral RB during the treatment period. And so we predicted a higher risk for the next sibling. So we had to counsel the parents saying that there is a higher risk for the next sibling to have a similar retinoblastoma because both the father and the proband had a very similar mutation. And here we did do the sibling screening. And since there was a familial germline mutation, there was a high risk of developing RB, was already explained to the parents, and the father's eye was normal by retinal examinations. The parents had been informed to bring the sibling early for screening. The child was brought in as early as 62 days and found to carry the same mutation as the father and brother and had a bilateral retinoblastoma. Now, we have a situation where one twin had a retinoblastoma with squinting, and the other twin had a retinal scar. We were not sure whether it was a regressed retinoblastoma. So when we did a genetic screening, we found out that there was no mutation in the parent's blood, and there was a de novo germline mutation in the blood of one twin and did not have any mutation in the other twin, which meant that this twin B is not having the disease, retinoblastoma, and this twin B is not going to be passing on the retinoblastoma to the offspring, whereas this twin has to be concentrated on for the offspring as well. So this is how we counsel. Now next is a unilateral RB, group E. There was no family history, but this child had a germline mutation identified in the blood. A word of caution here again and again, the teaching has often been only bilateral tumors have been inherited. Please understand, unilateral tumors can also be inherited and can be passed on to the offspring. So a genetic analysis is mandatory in unilateral and bilateral tumors. Now, there was a unilateral RB patient who had an enucleation many years ago. There was no family history of retinoblastoma or any other cancer in the family. So the person was 29 years old at this point of time and wanted to know whether there was any risk of retinoblastoma for her offspring because she was going to get married. Since there was no mutation found in the patient's blood, it was explained that there was less than 1% chance of getting retinoblastoma in her offspring, as it was in any case. Now, there was another patient who had a unilateral RB whose eye was enucleated, and there was no family history again of retinoblastoma or any other cancer. The person was 18-year-old, and that child wanted to know if there was any risk for additional cancers. And since there was no mutation found in the patient's blood, we explained that there was very less chance of getting an additional tumor as well as any passing on the tumor to the offspring. Now, this was a patient whose grandfather had a brain tumor, and since the patient had retinoblastoma, there was no family history of retinoblastoma. They wanted to know if this could occur in the next sibling as well. Since there was no mutation in the blood of the proband, and since there was no family history and none of the others showed any mutation, we explained to the parent that there is no chance for the next sibling to have a similar retinoblastoma. Now here again, we had a proband with bilateral retinoblastoma. This deletion, the patient had a deletion, and that deletion was inherited from the father, who again seemed to be an unaffected carrier. So we explained that there is an increased risk of retinoblastoma for the next sibling, and immediately after birth of the next sibling, the eye was examined and the genetic test was performed for that sibling, and it was found that the eye was normal and the genetic testing did not reveal any mutation, and hence we have eliminated the risk of RB in that child. Now, yet another example here, the proband's wife was pregnant. There was a familial retinoblastoma with 4 affected members. The proband and the mother had a similar deletion pattern, and the family wanted to know if there was a risk of retinoblastoma in the growing embryo. And unfortunately, on doing an amniocentesis and doing a prenatal testing, genetic testing, we found out that the fetal DNA also showed a similar mutation, and this was explained to the family. So in summary, tumors are caused by genetic aberrations, but that does not mean that all patients will inherit the disease, and does not mean that tumor in all cases are heritable by the next generation. Thank you very much.
Thank you, ma'am, for this wonderful lecture. It was quite informative for all of us. Thank you. So lastly, we'll be moving on to our next lecture. I invite Professor Dr. Jyotimari Biswas, Director of Uveitis and Ophthalmic Pathology Department at Shankar Nethralaya, Chennai. He is also a member of the International Uveitis Study Group, American Uveitis Society, and International Ocular Infection Society. He will be highlighting about the role of an ophthalmic pathologist in the diagnosis and treatment of intraocular tumors. I invite you, sir.
I can't open my video.
Yeah, that's
At the outset, I like to thank Sankara Academy of Vision and Sankara Eye Hospital for giving me the privilege to talk on World Cancer Day on ocular and oncology for the postgraduates webinar. I'll be talking on role of ophthalmic pathologist, intraocular tumor. This talk is mainly for the postgraduates, and I'll be talking on the very basic aspects of role of ophthalmic pathology in intraocular.
Dr. Tejas,
More
can we
common
pause
intraocular tumors received in the ophthalmic pathology lab is retinoblastoma. Little common, less common is malignant melanoma of the choroid. In nowadays, we see the vitreoretinal lymphoma specimens like biopsy, fine needle aspiration biopsy, and rarely chorioretinal biopsy. Rarely we encounter such tumors like meduloepithelioma or leiomyoma. In case of retinoblastoma, the role of the clinician is to provide a globe, enucleated with 10 millimeter or more of the optic nerve, which is very important.
Hello?
Sir, I'm just asking JB sir, can we switch on your video, sir?
Yeah, I cannot switch on that.
1 minute. I will do it from here, sir.
Yeah.
No.
Okay.
Yeah. Can I start, sir?
Yeah.
Yeah.
Yeah, thank you, sir. So we can start from first, I think, the first part.
Important to assess the optic nerve invasion of the tumor. Communication is important, providing history and clinical details, and usage of proper fixative and leveling done before sending the specimens. Here, I will be talking on retinoblastoma first, which is the most common intraocular tumor in the children. Retinoblastoma, what we do in the pathology lab, we do the grossing, transillumination, cutting the globe, bread loaf section, paraffin embedding, sectioning, staining, and reporting. So from a globe which we received, we prepare a slide for evaluation under microscope. Transillumination is done after grossing to find out the suspected intraocular tumor location, and sectioning is done to involve the tumor mass. Pupil optic nerve section is made, and nowadays we do the bread loaf section of 3 extra calots is prepared, as well as surgical end of the optic nerve is cut separately. Role of the pathologist first is to confirm is it retinoblastoma or not. Second is the growth pattern, whether it's endophytic, exophytic, diffuse infiltrating. Endophytic will be towards the vitreous cavity, exophytic will be towards the sclera, diffuse infiltrating will be diffusely infiltrating the retina. Differentiation is then looked for, whether it's well differentiated with the rosettes or sometimes florets, and undifferentiated. Retinoblastoma role of the pathologist is most important is the optic nerve involvement assessment, whether it's present or absent. If it is present, if it is involved beyond lamina cribrosa or not, and surgical end of the optic nerve is involved or not. Choroidal involvement is assessed, whether it's less than 3 millimeter or more than 3 millimeter, or there is any extrascleral extension also looked for. Pupil optic nerve section of the globe in a retinoblastoma, we see a chalky white mass lesion classically. And the histopathology microscopic section, we see the pink areas, which is a necrosis, area of necrosis, and the deep blue color, which correspond to the ultrasonographic findings of calcification noted. In the well-differentiated form of the retinoblastoma, we see the flexner intestinal rosette, where the columnar cells is located around the central. There's a neural fiber is seen. Homarite rosette is not specific for retinoblastoma, and retinoblastoma is more common, it's a round or oval, and there's no rosettes or floret formation. Then you look for an invasion of the tumor, anterior segment invasion, or choroidal or sub-RP involvement. Choroidal invasions here is seen in the full thickness of the choroid is involved, and we look for optic nerve invasion and see whether the invasion has gone beyond lamina cribrosa or not. In case of malignant melanoma of the choroid, we see that grossing, we look for extrascleral extension. Staining is done, both bleached and unbleached preparation, to find out the cell type. And pathology, we look into that, what cell type is seen. Is it spindle, or is it epithelioid, or mixed? Scleral and extrascleral extension is looked for, and the vortex vein involvement. Here is the case of malignant melanoma of the choroid, which enucleated, showing a mushroom-shaped mass lesion, and the histopathology will show the Brooks membrane rupture, and the tumor is jutting out from the choroid. Malignant tumor melanoma of the choroid, the cell type is spindle A or spindle B cells is seen in the spindle cell type of the tumor. Spindle cells is the nucleus is small and thin and often like a stripe. Nucleoli is more seen in the spindle B cells, and these cells are very cohesive, whereas in case of epithelioid cells, which is large and where is prominent nuclei and prominent nucleus with nucleoli is seen. Macular syndrome is also seen in pathology. This is an 8-year-old girl, persistent hypopia and uveitis, not responding to the topical and systemic steroid. There is a white hypopia is present. We suspected retinoblastoma, and we went ahead with the anterior chamber tap, which showed basophilic large cohesive tumor cells suggestive of retinoblastoma. This is a 7-year-old girl, acute lymphoblastic leukemia, Peripheral blood smear was normal, cerebrospinal fluid was negative for malignant cells, and you can see that white hypopion with convex border with iris and also iris infiltration. Anterior chamber TAP was done, and we could see the lymphoblast blue cells with hyperchromatic nuclei and scanty cytoplasm, suggestive of acute lymphoblastic leukemia spread. In case of primary vitreoretinal lymphoma, which we are increasingly getting recognized, and we do that clinical suspicion is first, followed by the multimodal imaging, and here we require vitreous biopsy, or sometimes fine needle aspiration biopsy, retinochoroidal or choroidal biopsy. Vitreous biopsy specimen should reach the pathology laboratory as soon as possible, preferably within half an hour. And the vitreous biopsy should be carefully looked up for the malignant cells, which is seen often in the necrotic background, and sometimes inflammatory cells is accompanied. In cell block preparation, we can see the pleomorphic large lymphoma cells with hyperchromatic nuclei and scanty cytoplasm. Immunohistochemistry is important to find out the cell type, whether it is the T cell or B cell lymphoma. Here is the CD25 positive, indicating B cell lymphoma. Here is a 57-year-old lady, painless gradual dimness of vision for 9 months. She was diagnosed as tubercular choroiditis, and we can see that leopard skin-like appearance. We suspected primary vitreoretinal lymphoma, and we did the fine needle aspiration biopsy. Fine needle aspiration biopsy showed in the necrotic background large lymphoma cells, suggestive of primary vitreoretinal lymphoma. MRI brain 6 months after showed CNS lymphoma. How to confirm primary vitreoretinal lymphoma? The pathologist does the cytospin smear, cell block, and do the multiple sections, and histopathology of the tissue sample from the chorioretinal biopsy or choroidal biopsy. Immunohistochemistry done to identify the clonality of the cells like T cells or B cells, and interleukin assay is done, IL-10, IL-6 ratio, and nowadays we do the MYD 88L265 mutations. In vitreous cytokines, IL-10, IL-6 ratio is increased in vitreoretinal lymphoma, and more than 1.0 is suggestive of primary vitreoretinal lymphoma. What's new is the MYD L265 mutations, which we have done from the vitreous specimen in our institute, and we found the sensitivity is 88.9%, specificity of 91.6%. Once in a while, you see the tumors like this. Is the pink color tumor at the angle, and we did the sclerouvectomy, and here you can see the blue mass is seen, and this on histopathology shows spindle cells with fibrillar cytoplasm, and here we require immunohistochemistry where smooth muscle actin and vimentin is done, showing positivity indicating leiomyoma. So take home message. Ophthalmic pathologists play an important and indispensable role in the diagnosis and management of various intraocular tumors. They can make clinicians to understand better by clinical pathological correlation. William Osler, a great clinician, has told, as is our pathologist, so is our practice. It is very true in intraocular tumor pathology in particular. Thank you very much.
Thank you for the opportunity.
Thank you, sir, for this wonderful lecture. Sir, I'd like to now open the floor for questions from our audience. So first, I'll be asking a few questions which were posted on our YouTube link. First one would be for Dr. Usha ma'am. This is regarding a pregnant lady with known germline mutation and one affected child. Is there a role for ultrasound to diagnose RB in the unborn child and deliver the child earlier? Ma'am, your view?
Yeah, there's been a lot of reports stating the relevance of, in fact, the relevance of ultrasonography, but we need good people to diagnose to concentrate on the orbit, and it's very, very difficult. We have tried it ourselves. It's very difficult, but what we can suggest is to bring in the baby as early as possible, and we need not, in fact, overdo it. I would suggest that If we have a good sonologist who can concentrate on the area of the orbit, it'll be good. If we can pick up that speck of calcification earlier on, you can do a preterm delivery and then bring in the child. Otherwise, you could still educate the parents to bring in the child as early as possible for an examination.
Yes, ma'am. Ma'am, the next question is also in a patient carrying germline RB1 mutation, what is the risk of adult onset or late onset retinoblastoma? And what would be the role of prenatal testing with amniocentesis?
Okay, for a person with a germline, the risk is you could still have the offspring could be affected, and a prenatal amniocentesis could be advocated in these patients. Yes.
Yes, ma'am. And ma'am, about the adult onset, ma'am, what is the risk for in a known patient with germline mutation? What is the risk for late or adult onset retinoblastoma?
In a known case of a germline mutation, you will have to have a check on the progression, because we have seen that even unilateral cases on treatment turning bilateral, and patients with retinoblastoma getting additional tumors. Yes, we should be on the lookout.
Yes,
but
okay, thank you.
Not personally had any case where we've had an adult onset with the germline mutation, but there is a chance for a adult onset. Yes.
Yes, ma'am. Okay, thank you, ma'am. The next question would be for Santosh, sir. Sir, what is the ideal case for intraarterial chemo?
Well, the maximum benefit by intraarterial chemotherapy is in group D and E retinoblastoma. So ideally, if you have a choice of not giving intraarterial chemotherapy, then group B and C can very well be managed with systemic chemotherapy. Of course, it has systemic side effects, but the maximum benefit the child receives is in group D and E retinoblastoma.
Sir, and what would be the drug of choice for intraarterial? So whether melphalan or topotecan is better, or single drug or double drug? What is the preferred
Well,
option?
the most preferred drug, the standard of care, is melphalan as a single drug. And for reasons which are more financial than anything else, and also for the rapidity of chemo reduction that it can be achieved, then we can combine melphalan with topotecan and carboplatin. So 3-drug protocol is what we follow, because then the number of cycles can be limited to 3. Suppose we follow a single drug cycle, then the number of cycles that may be required would be more. Because of financial issues, we limit our children to 3 cycles generally. And for us, 3-drug protocol suits well.
Yes, sir. Yes, sir. Now moving on to the next question, sir. How do we differentiate between an active and inactive vitreous seed?
Well, there are vitreous seed regression patterns that have been described. It all depends on the type of seeds that are found initially. Now, as Divyan mentioned, there are different types of vitreous seed, primary vitreous seed morphology that has been described by Munia. And depending on what type of seed was found, the regression pattern can be deduced. For example, if you find a spherical vitreous seed, plump, fluffy spherical vitreous seed, then that can regress into a crenated calcified seed, or it can regress into a hollow seed where there is nothing inside it, but a very simple rim that is seen. So it's basically a hollow seed. It regresses into a hollow seed. But if you already have dust, as vitreous seeds, then it disappears more often than not, completely disappears, dust goes away, or it may leave refractile calcified crystals. So it all depends on the type of seeds that you find primarily, and based on that, you assess the regression pattern. And stability over time is more important. If a seed remains so for, say, 6 months on all consecutive EUAs, then it is regressed clinically.
But that is more of a clinical judgment, sir, I think. Okay, so next question is, how do we rely, how much do we rely on FFA, OCT, MRI, and CSF analysis while staging the disease?
Well, FFA, OCT are not important for staging the disease. They are mainly, FFA is mainly for very, in situations where there is gross diagnostic dilemma, or if you really want to know the vascular pattern of the tumor, etc. But FFA is clinically not useful. OCT is also not clinically useful unless you are trying to detect preclinical tumors, which, where you think there may be a tumor in a heritable situation and you have access to OCT under general anesthesia, where you might want to screen the posterior pole, etc. That is where the role of OCT comes. MRI is important because with MRI, you can know ciliary body extension, you can know the thickness of the choroidal invasion, you can know optic nerve extension even before you start treatment. So MRI definitely has a very clear role in staging the disease. What else did you say? CSF cytology.
CSF analysis, yes.
CSF analysis is not indicated in patients who don't have clinical risk factors, because diagnostic yield is extremely low, extremely low. So is bone marrow biopsy. So if a patient has clinical risk factors such as neovascular glaucoma, anterior segment infiltration, ophthalmic eye, high intraocular pressure, or on MRI there is choroidal invasion already, ciliary body invasion already, or optic nerve invasion, then there is a point in doing CSF cytology and bone marrow biopsy as a baseline measure.
Okay, yes, sir. Thank you, sir. Next question will be for JB, sir. Sir, how do we fixate and transport a tissue when we are sending to the pathologist?
10% neutral buffered formalin, we put it in that one, and then send it as seal it and properly and send it.
Okay. Yes, sir. Okay. Thank you, sir. Any other questions, or shall we wind up this session? Divyansh, sir?
Yeah, thank you. It was a very informative session for all of us, ranging from classification to how to manage each and every individual case, from intraocular to extraocular retinoblastoma. And yes, most importantly, we have to go to the future, which is the siblings and progeny of that patient. So genetic analysis is very important, as madam has showed. And yes, the most important, how to diagnose a case, pre-operative, post-operative, adequately sending the tissue, as Sarah suggested, in formalin in most of the cases. And if we're suspecting lymphoma, it has to be either different medias are available, or if not, at least at the earliest in the saline itself can be sent. And depending what we are looking at the disease, then the decision needs to be taken. Yeah, it was a fantastic presentations from all the faculties, and yes, much more is awaited. So we go on to the next session.
Yes, sir. I invite Dr. Mahesh, sir, to take over for the next session.
Thank you, Dr. Divyansh, and thanks to Dr. JB, Dr. Santosh, Dr. Usha, and for Dr. Divyansh for a wonderful first session on retinoblastoma. Next, we'll be moving on to choroidal tumors, and once again we have wonderful faculty. And let me introduce the faculty. And Dr. Swati, her achievements belie her age. This young dynamic person is the head of Department of Ophthalmic Plastic and Facial Aesthetic Surgery and Orbit and Ocular Oncology at V Prasad Eye Institute in Hyderabad, and she is also the adjunct associate professor, University of Rochester. And she has numerous publications and continues to do yeoman work as far as ocular oncology is concerned. And next, it's my pleasure to introduce Dr. Vishal Raval. He is one of our own kin. So he's one of the very few people who do retina and ocular oncology. Dr. Vishal is the budding star as far as ocular oncology is concerned. And he's a consultant ophthalmologist with in disease and ocular oncology service, once again from V Prasad. And it's my pleasure to introduce our own Dr. Pradeep Sagar, a very young and dynamic consultant with us with Sankara Eye Hospital, Shimoga. He has done wonderful work on OCT of intraocular tumors, and in fact, like most of the evenings, he doesn't spend with his wife or his girlfriend, but with the OCT machine. That's the common joke which goes around in our hospital. So we'll start with the session on choroidal tumors, and we'll start with Dr. Pradeep Sagar, who will be speaking to us on Ophthalmic Manifestations classification. Dr. Pradeep, please. Can you hear Dr. Pradeep lecture?
I'm Dr. Pradeep. At the outset, I would like to thank the organizers for giving me this opportunity. Under the section of choroidal melanoma, I will be discussing the classification and the collaborative ocular melanoma study. Though an uncommon tumor, it's the most common primary intraocular malignant tumor. Ocular melanoma can arise from choroid, ciliary body, and iris, and the choroid is the most common site. To understand the classification of choroidal melanoma, we need to understand two dimensions. One is the basal diameter. We measure the largest basal diameter, as we can see in the color photograph and in the ultrasonography. The other dimension is the height. The height is measured from the base of the tumor to the apex of the tumor. The collaborative ocular melanoma study classified the choroidal melanoma into small, medium, and large melanoma. The small melanoma has an apical height of 1.5 to 2.4 mm and a basal diameter of 5 to 16 mm. The medium size melanoma has an apical height of 2.5 to 10 mm and a basal diameter of less than or equal to 16 mm. Large choroidal melanoma has an apical height of more than 10 mm, irrespective of the basal diameter, or a basal diameter of more than 16 mm. The COM study is the largest study in ocular oncology. It's a multicentric study which was conducted between 1987 to 1998. The COM study had 2 randomized controlled trials and an observational arm. The first randomized controlled trial was comparison between enucleation and enucleation preceded by external beam radiation therapy in large size melanoma. The second randomized controlled trial was comparison between enucleation and brachytherapy in medium-sized melanoma. The third arm is an observational study to study the natural history of small-sized melanoma. Coming to the first randomized controlled trial, that is the enucleation versus pre-enucleation radiation therapy. It included large-sized melanoma, which were randomized to either enucleation or an enucleation preceded by an external beam radiation therapy of the orbit. The estimated 5-year survival rate was 57% in the enucleation group and 62% in the pre-enucleation EBRT group. The tumor-related mortality at 5 years was 26% in enucleation group and 28% in the pre-enucleation EBRT group. At 10 years, it was 40% in enucleation group and 45% in pre-enucleation EBRT group. The local recurrence in the orbit was seen histopathologically in 5 cases in enucleation group and none of the cases in the pre-enucleation EBRT group. So there was no statistically significant difference between the two groups in terms of these parameters. Coming to the second RCT, that is the enucleation versus brachytherapy. It included the medium-sized melanoma, which were randomized to either a standard enucleation or brachytherapy with iodine 125. The cumulative mortality at 5 years was 19% in enucleation group and 18% in the brachytherapy group, and at 12 years was 41% in enucleation group and 43% in brachytherapy group. The histopathology confirmed metastasis was noted at 10 years in 17% of patients in enucleation group and 18% of patients in the brachytherapy group. So there was no statistically significant difference in these parameters. Coming to the third arm, which studied the natural history of small melanoma, they noted that the all-cause mortality at 5 years was 6% and tumor-related mortality at 5 years was 1%. The factors associated with tumor growth include increased tumor size, the increased tumor thickness, presence of orange pigment. So these are the orange pigments that are typically seen in choroidal melanoma, absence of drusen, absence of RPE changes surrounding the tumor, and presence of pinpoint hyperfluorescence on fluorescein angiography. One of the limitations of the study was the study did not include the ciliary body and juxtapapillary melanoma, so the results cannot be extrapolated to the ciliary body and juxtapapillary tumors. The major findings from the COM study are: one is a pre-enucleation EBRT of the orbit does not improve survival in large melanoma. The other finding is there is no difference in the survival of patients with medium-sized melanoma treated with either enucleation or brachytherapy. Thank you.
Thank you, Dr. Pradeep, for a very crisp and clear presentation on the classification. So next, I invite Dr. Vishal Raval. He'll be speaking to us further on choroidal melanoma, about the diagnosis, about the management. And Dr. Vishal, can you start a presentation, please? It's a pleasure having you with us once again.
Thank you, sir, for the opportunity. Good evening to one and all. Thank you for the opportunity. I will be presenting on choroidal melanoma, clinical features and management. Now I have no financial disclosure. As we all know, choroidal melanoma is the second most common intraocular tumor, metastasis being the most frequent. It's a rare disease, and as per the SAES database, age-adjusted incidence of UM melanoma accounts for 5.1 per million in US population. Comparing with that Asian population, it ranges from 0.2 to 0.6 per million. The age of presentation, when compared with the Caucasian population, in Asian population is a decade earlier, around 40 to 55 years, as compared to in whites, which is around 50 to 60 years. While development of UM melanoma is largely considered to be a sporadic event, certain risk factors such as light iris color, light skin color, formation of freckles, Northern European ancestry, and rarely family history of UM melanoma have been reported to predispose individuals to UM melanoma. Other risk factors such as presence of choroidal nevi, which has a risk of 1 in 8,000 transformation from nevi into melanoma, and presence of ocular edema melanocytosis, also known as nevus of Ota, which predisposes the individual to a risk of UM melanoma, which accounts for 1 in 400 Caucasian population. Other predisposing risk factors in terms of genetics, such as presence of BAP1 predisposition syndrome, do increase the risk to individual for presence of UM melanoma. Ultraviolet light, which is a known risk factor for skin melanoma, however, is not a risk factor for UM melanoma. Clinical features, as we all know, it all depends on the size and the location of the tumor. Tumors involving the posterior pole or the macula, patients do present with decreased vision or blur vision, or tumors which are larger in size might be associated, patients might be presenting with photopsia, floaters. Very rarely, the tumors which are beyond the equator, they might be just a coincidental finding on routine fundus examination. Anterior segment evaluation is very, very important, particularly in case of posterior choroidal melanoma, because there are a few important pointers which we need to be very clinically need to diagnose and see, particularly in case of posterior choroidal melanoma. First is presence of dilated episcleral vessels, which are usually seen under the conjunctiva, which are classically known as sentinel vessels. It highlights the importance of ciliary body involvement. Second is presence of small areas of pigmentation seen 1 to 2 millimeters from the limbus. Usually these are areas where there is scleral perforators, where the uveal melanocytes might be perforating the sclera into the extraocular extension. Other anterior segment features, such as presence of large pigmented choroidal lesion seen behind the posterior capsule, presence of anterior segment inflammation, presence of focal or sectoral cataract in the area where the pigmented lesion is seen on diffuse illumination, and vitreous abnormalities in form of either pigments due to tumor necrosis or vitreous hemorrhage due to tumor breaking to the Brooks membrane. Last but not the least, secondary glaucoma. I think that is also very important feature of choroidal melanoma, particularly large choroidal melanomas, which can push the iris lens diaphragm anteriorly, leading to secondary glaucoma. On fundus examination, usually choroidal melanomas presents as smooth dome-shaped pigmented choroidal lesion with overlying retinal blood vessels normal. The color varies from grayish to brownish in color, but in few cases it can range from dark brown to creamy yellow, also known as a melanotic variant of choroidal melanoma. Coming to size and shape, usually posterior pole median sized choroidal melanomas are dome shaped. due to intact Brooks membrane. However, in few cases, the overlying Brooks membrane might rupture, leading to mushroom or collar bottle shaped configuration, as seen in one of the photos. A rare but important presentation of melanoma is diffuse melanoma, which is an infiltrative form of melanoma, which is usually having a horizontal growth and less of thickness. And very rare feature of choroidal melanoma is retinal invasion, forming a spear known as snap Ronnie type melanoma, which can ultimately lead to a vitreous seeding of choroidal melanoma. Clinical features, as we all know, after looking at the pigmented choroidal lesion, look at the shape, look at the size, document the size of the lesion in terms of both larger basal diameter as well as the thickness. Look for the distance of the tumor from the fovea and the optic nerve head. Look for the surface lesions in form of either overlying orange pigment or lipofuscin deposition, presence of subretinal fluid in and around the lesion, presence of drusen, and serous or exudative retinal detachment. Transillumination is one of the important OPD-based technique to demonstrate particularly the anterior extent of the lesion and make a diagnosis of cilio-choroidal melanoma. It does play an important role, particularly in intraoperative, particularly during plaque placement, in order to measure or document the anterior extent of the choroidal melanoma. Important feature is to distinguish leiomyomas from choroidal melanoma, that leiomyomas usually don't transilluminate, while choroidal melanomas usually transilluminate. Diagnosis, as we all know, choroidal melanoma is a clinical diagnosis. Few important imaging modalities do require, particularly in suspected cases where it might simulate choroidal granulomas or inflammatory pathologies. An invasive test such as fluorescein angiography or diagnostic biopsy might also be required in few cases. Feather fundus photography usually helps to get a good baseline imaging to not only demonstrate the size and the horizontal extent of the lesion, but also in cases where you want to document the growth of the lesion, it does helps. It also helps us to document the associated features such as features of radiation retinopathy, neovascularization of disc, and elsewhere. This is one of the cases where you could see there is a small pigmented choroidal melanocytic lesion in superior temporal arcade. After 6 months of follow-up, because there was not much of thickness and there were no high respiratory features, patient was asked to follow. At 6 months, you could see there is a small extension at the posterior edge of the lesion towards the fovea, and thus the color fundus photograph documented growth of the lesion, thereby confirming the diagnosis of choroidal melanocytic lesion transforming into melanoma. Fundus autofluorescence does helps to outline the entire extent of the subretinal fluid as well as areas with RP atrophy, and also it highlights the lipofuscin deposition over the lesion as hyperautofluorescent lesions. Ultrasound is the most common primary diagnostic test that helps you to confirm diagnosis of melanoma. Usually in ultrasound, the lesion resembles a smooth dome-shaped choroidal lesion with high surface and low internal reflectivity on A scan, also known as positive kappa angle. It also helps you to assess the tumor-associated other features such as presence of retinal detachment or vitreous hemorrhage, and also in few cases where it helps us to demonstrate the extraocular extension of the tumor. In cases where there is breakthrough Brooks membrane, OCT is not a very important diagnostic tool to confirm melanoma. However, it does help us to document the compression of overlying chorocapillaries and other features in form of loss of photoreceptors and outer retinal damage, which are not usually seen in cases with choroidal nevi. Other features such as subretinal fluid, macular edema and schisis can also be documented with OCT. Fluorescein angiography is an important diagnostic tool to demonstrate the vascularity within the lesion. Usually the tumor is hypofluorescence due to blockage of the choroidal blood flow by the pigment. However, in a few cases, it might show few hyperfluorescent spots due to lipofuscin deposition. Classical feature of double circulation pattern consisting of internal circulation within the lesion and normal vascularity of the overlying retina is a common feature seen with choroidal melanoma. Angiography, indocyanine green angiography demonstrates tumor hypocyanosis to all the phases of choroidal melanoma. In order to determine the predictive risk factors for choroidal nevi transformation melanoma, Shields et al. Have come with a mnemonic which shows all the high risk features which we need to look particularly in cases with choroidal nevi, and depending upon the number of features present, we can give a probability of as close to as 10% in cases with one risk feature to as high as 50 to 70% in patients presenting with 5 to 7 risk features. Biopsy is usually not warranted for choroidal melanoma. However, in few cases with simulating clinical patterns such as amelanotic uveal tumor, patients having history of underlying carcinoma or media opacities, it might be needed. As per Singh et al., in close to 1 to 2% of cases, diagnostic fine needle aspiration biopsy is required to confirm the diagnosis. Usually on cytology, we see either epithelioid or spindle cell variant of choroidal melanoma with presence of melanin pigmentation. Treatment of choroidal melanoma is usually depending upon the size, particularly the basal diameter and the height of the lesion, as well as per SCOM's classification, the tumor is differentiated into 3 types: small type, medium size, and large size. Modalities available are transpupillary thermotherapy, plaque brachytherapy, and enucleation. Newer treatment options such as proton beam radiation and light activated radiotherapy are under investigation. Transpupillary thermotherapy is usually done for tumors up to 2.5 millimeter height, and usually it is done in conjunction with the plaque brachytherapy, particularly for edge, which is involved in the parapapillary area. However, there is high risk of recurrence, close to 17%, and few cases do report extracellular extension of the tumor. Plaque brachytherapy is usually done for medium-sized tumors, height varying from 2.5 to 10 millimeters, and basal diameter less than 16 millimeters. Isotopes available with us are particularly ruthenium-106, which is used for lesions less than 6 millimeter in thickness, and iodine-125 for lesions less than 10 millimeter thickness. Various types of plaque are designed as per the requirement, round, notch, or curvilinear, as seen in the corresponding photograph. This is one of the case with the pigmented choroidal lesion diagnosed to a choroidal melanoma, which was treated with iodine-125 plaque. Post plaque 6 months follow-up, you could see the tumor has reduced in size as well as corresponding retinal pigment epithelial atrophy secondary to plaque radiation. Ideal dose, what we usually apply for choroidal melanomas, ranges from 85 to 100 grays given to the tumor apex. Few complications which we need to keep in mind, particularly related to radiation given to choroidal melanoma. It ranges from radiation retinopathy, cataract, neovascular glaucoma, vitreous hemorrhage, and retinal detachment. Enucleation is usually reserved for patients with large tumors more than 80 millimeter in size or patients with extraocular extension. Follow-up is usually done every 3 months to document the regression of the tumor, not only on color fundus photograph, but also on ultrasound. After that, every 3 months, the patient is followed for first year, followed by every 6 months for next 5 years. After 5 years, the patient is followed up every yearly. As we all know, the rate of local recurrence decreases after 5 years. An also important feature is to look for the systemic metastasis, particularly in cases with large sized tumors. This is one of paper from Shields et al. Where they have demonstrated the risk of systemic metastasis choroidal melanoma depending upon the size. As you can see, this, the probability of metastasis starts from as low as 2% at 3 years to as high as 49% at 10 years for large choroidal melanomas. Other risk factors include large size of the tumor at presentation, epithelioid variant of melanoma, presence of other genetic mutation features such as monosomy 3 and BAP1 mutation does increase the risk of systemic metastasis. Prognostic biopsy is usually performed to demonstrate the class of the tumor which is actually present within the lesion. Usually the test which is commercially available is gene expression profile, which examines 15 genes to generate a prognostic subgroups. Class 1A tumors, usually they carry low metastatic risk. Class 1B tumors have intermediate risk, and class 2 tumors have high risk. Depending upon the category the patient is under, if patient has a class 1A or 1B tumor, they are usually followed up every quarterly to 6 months with ultrasound liver to document any subclinical or early hepatic metastasis. As we all know, in majority 85% of cases, the metastasis goes to the liver, followed by lung and then bone. In class 2 tumors, usually the patient is referred to hepatic oncologist to monitor every quarterly or 6 monthly to look for any subclinical or early hepatic lesions. And in cases with doubt, CT or MRI also may be needed. So in a nutshell, I would say few important risk factors for choroidal melanoma, such as choroidal nevi and nevus of Rota, should be kept in mind, particularly in context related to predisposing factors for choroidal melanoma. Anterior segment evaluation is very, very important, and look for either sentinel vessel or scleral perforators, which might highlight the underlying presence of ciliary body enlargement. And last, depending upon the size of the lesion, the tumor might have either mushroom or collar button shape when the tumor breaks through Bruch's membrane, or look for associated features such as serous retinal detachment, exudative detachment, or in few cases vitreous hemorrhage. Ultrasound is the diagnostic tool to confirm the diagnosis of melanoma. Autofluorescence ICG does helps in few cases to not only document the lesion size, but also to rule out other inflammatory choroidal granulomas. Treatment is usually done as per the size of the lesion. Smaller tumors are treated with transpupillary thermotherapy, medium size with plaque brachytherapy, and larger size tumors ultimately requires enucleation. Not to forget is regular surveillance with the medical oncologist to look for any early signs of liver metastasis is very, very important, particularly in case with choroidal melanoma. I'd like to thank my fellow Dr. Ankit for helping to make this presentation, and also Dr. Arun Singh for mentoring all through my fellowship. Thank you.
Thank you, Dr. Vishal, for a wonderful comprehensive lecture covering all aspects of uveal melanoma. So we'll go on to our next lecture before we have the discussion. Now I invite Dr. Swati, who will be speaking to us on the other choroidal malignancies. Dr. Swati, please.
Tumors other than choroidal melanoma. I'll be talking about hemangioma, metastasis, osteoma, lymphoma, and granuloma. Choroidal hemangioma is the most common vascular tumor of uvea. It's a vascular hamartoma, and it is basically of two types, circumscribed or diffuse. Circumscribed choroidal hemangioma, it remains asymptomatic till 2nd to 5th decade of life and then may go on to develop symptoms. It is associated with hyperopic shift due to anterior displacement of retina. It appears as a classic orangish red lesion posterior to the equator and mostly in the posterior pole. This is a classic fundus picture where we can see an orange lesion that is present inferotemporal to the optic disc. Diffuse choroidal hemangioma, it is associated with Sturge-Weber syndrome, and it has earlier age of onset when compared to that of circumscribed choroidal hemangioma, and it occurs on the ipsilateral side of the port wine stain. On examination, there'll be a brighter red reflex when compared to that of a normal red reflex of the opposite eye, and there will be orangish red thickening of the choroid, giving a tomato ketchup appearance. We always have to look for other ocular signs of Sturge-Weber syndrome like the developmental glaucoma or the episcleral hemangioma. This is an example of diffuse choroidal hemangioma where we can see port wine stain on the right side of the face. And this is the fundus image of the same patient, giving a orangish red appearance to the fundus. On autofluorescence, choroidal hemangiomas, they appear hypoautofluorescent with associated hyperautofluorescence of the orange pigment and the subretinal fluid. On ultrasonography, there is an acoustically solid lesion corresponding to high internal reflectivity on A scan. This is the B scan image of diffuse choroidal hemangioma showing diffuse choroidal thickening with a nodular component. FA does not provide much information for choroidal hemangiomas except that there will be early filling and late leakage and staining. ICG is more useful in these cases where there will be early filling and late washout phenomenon with choroidal hemangiomas. On OCT, there is a hyporeflective choroidal thickening with backshadowing with a dome-shaped anterior surface. And there is no compression of the choriocapillaries, and there will be enlargement of small and medium-sized choroidal vessels. So whenever we see these findings, it is a case of choroidal hemangioma. There are various differential diagnoses that can be considered, including melanoma, metastasis, and posterior scleritis. Various treatment options are available, but each case may be different. Like in this case, who presents with chronic vision decrease with a good visual acuity, with a lesion in the posterior pole suggestive of circumscribed choroidal hemangioma, and OCT showing a lesion but without subretinal fluid. In these cases, it is better to just observe the lesions. While if it is acute onset of vision decrease with significant loss of vision with an associated lesion with OCT showing subretinal fluid, these lesions should be treated. And the treatment option, it depends upon the location of the lesion, the size of the lesion, the thickness of the lesion, and the extent of the lesion. For example, this patient was treated with plaque radiotherapy, where we can see that after treatment, the lesion completely disappeared and subretinal fluid also disappeared. Next, moving to choroidal metastasis. Uveal metastasis is considered to be the most common intraocular malignancy, with choroidal metastasis constituting 88% of uveal metastasis. And it can be the first presenting sign of systemic cancer, most common being breast and lung CA. They may remain asymptomatic or can develop symptoms, including pain if the patient has secondary glaucoma. They can be unilateral, but are often bilateral and multifocal, and they have a very classic ill-defined dirty yellow colored subretinal lesions with subretinal fluid. Like here, we can see a dirty yellow lesion with subretinal fluid. And this is another example where the patient has had gastric carcinoma with the choroidal metastasis and extensive subretinal fluid. The B-scan shows an acoustically solid lesion with variable internal reflectivity on A-scan. And the OCT shows a very classic image of what is known as lumpy bumpy appearance, where it is very irregular anterior surface of the choroid. So whenever this is seen, this is a case of choroidal metastasis. It has various differential diagnoses ranging from melanoma to lymphoma. The management, it is very important to systemically screen the patient to identify the primary cancer and to treat the primary cancer. Choroidal biopsy may be required when the diagnosis is uncertain. Now, the management, of course, depends upon the systemic status of the patient. Now, this patient had ocular metastasis and brain metastasis, and the patient underwent external beam radiotherapy, and can be seen that the tumor nicely regressed. Choroidal osteoma is a benign ossifying tumor where the choroid is replaced with mature bone, and it is more common in females, and the symptoms usually manifest in late teenage or in early 20s. It is associated with vision symptoms, and the lesions are usually juxtapapillary or peripapillary, and it has a very characteristic yellowish white to orangish red subretinal lesion with very well-defined scalloped or geographic margins. It can undergo decalcification with time and is rarely associated with the choroidal neovascular membrane. Now, this is a fundus picture of a calcified choroidal osteoma, and this is a picture of decalcification that is noted within the choroidal osteoma. Now, the B-scan and A-scan has very characteristic features where there is a classic acoustically solid lesion that is noted causing backshadowing, which is known as a pseudo-optic nerve. And on A-scan, it has very high internal reflectivity, and this persists even on low sensitivity. The OCT has interesting feature of the lamellar pattern in the choroid, which looks like bony trabeculae. So this is a classic feature of choroidal osteoma. And the OCT feature in the area of decalcification shows chorioretinal atrophy. The treatment, it depends on if it is asymptomatic, then it is simply better to observe the lesion. If associated with choroidal neovascular membrane, then that has to be treated. And if the lesion is progressing, then a PDT or TTT or laser photocoagulation may be needed to contain the progression. The prognosis, it is usually associated with poor vision, tumor growth, choroidal neovascular membrane, and decalcification at 10 years from diagnosis. Choroidal lymphoma is a rare intraocular tumor. It can be primary or secondary. Primary is usually associated with low-grade malignancies, while secondary is associated with high-grade malignancies. The primary lymphoma may have very mild symptoms, while secondary choroidal lymphoma has more ocular findings, and both types of lymphomas are associated with diffuse, ill-defined, multifocal creamy yellow patches in the choroid, like what we see here. The B-scan has a very characteristic picture where there is a acoustically hollow choroidal thickening with acoustic hollow episcleral extension that would be seen on B-scan. This is the OCT image where there will be an undulated surface. So whenever we see a choroidal lesion with C6 surface, then it is because of choroidal lymphoma. There are various differential diagnoses that may be considered in such cases. And the management, it is very important to systemically screen the patient to know if there is any systemic disease. And if it is a focal disease, it can be treated with plaque radiotherapy. Sometimes if it is diffuse, may need external beam radiotherapy. And if associated with systemic disease, will need systemic chemotherapy. Last, moving to choroidal granuloma, they present as amelanotic choroidal lesions and may be associated with conditions like tuberculosis or sarcoidosis. They may be unilateral or bilateral. The B-scan shows an acoustically solid lesion, and A-scan has a high surface reflectivity and variable internal reflectivity. And OCT, it has a very classic picture known as contact sign, where there will be contact between the choriocapillaries RPE complex and neurosensory retina. The management, it depends upon the systemic disease. So systemic workup is very important, and we have to treat the systemic disease. In summary, other than choroidal melanoma, there are many other non-melanotic choroidal tumors that can occur, and a good fundus examination, ultrasonography, and OCT features help in accurate diagnosis. Thank you very much for your kind attention.
Thank you, Dr. Swati, for taking us through the brilliant lecture on all the other choroidal lesions. And we have had wonderful lectures from all the faculty, and there are some questions in the chat box. And Dr. Kritika Jain wants to know from Dr. Vishal, how do you differentiate an optic disc melanoma from a melanocytoma?
Yes, so I think good question. So usually I think first is a clinical diagnosis, both optic disc melanocytoma as well as juxtapapillary or parapapillary choroidal melanoma. Both are clinical diagnosis. On clinical examination, the optic nerve head melanocytoma, usually the lesion will be seen on over the optic disc, with sometimes the tumor might kind of transform or kind of sweep into the adjacent retina or the choroid. The important feature, I think what I want to say is to differentiate the color. Usually optic nerve melanocytoma will be kind of dark brown to black in color, as compared to choroidal melanoma, which will be kind of light brown to medium brown in color. And other feature, what you want to see, particularly on imaging, if you can do on B-scan, you will see optic nerve head melanocytoma will show a high reflectivity right over the optic nerve head or the optic disc, as compared to the juxtapapillary or the choroidal melanomas, which usually don't come over the optic disc, but they might extend along the optic disc into the optic nerve. So I think that are the few features which I would like to say when to differentiate between melanocytoma and melanoma.
You did mention that the transillumination is negative in leiomyoma. So can I just make a clarification? So the shadow is not shown in a leiomyoma. In contrast, there's a black shadow shown in a melanoma because it's pigmented. So in transillumination leiomyoma, you don't see the black shadow, but in a melanoma, you see a black shadow. Probably that's what Dr. Vishal wanted to mention. So Dr. Swati, you wanted to add anything about the differentiation between melanoma and melanocytoma?
Thank you, Dr. Mahesh Shanmugam. First of all, thank you very much for inviting to this forum, and I'm very happy to be part of this. In addition to the points that I think Vishal mentioned, one other specific feature that melanocytoma has is it has feathery margins, usually which is not seen in melanoma. Melanoma usually it has well-defined or the scalloped margins, while in melanocytoma it usually has the feathery margins. That is one other differentiating feature that helps us to differentiate between melanoma and melanocytoma. So yeah, that's what I would add to that question.
And sometimes it can be difficult in the sense like the melanocytoma can throw seeds into the vitreous cavity. That doesn't mean that it's converted to malignancy, just that when that undergoes necrosis, it can throw seeds. And sometimes it can be very difficult. It can convert to a melanoma, so a serial follow-up is what is possibly recommended. So another question from Dr. Ramkumar to Dr. Vishal is like, there is a same site recurrence of melanoma after plaque brachytherapy. So he wants to know what is the treatment if there is no evidence of systemic metastasis. How would you treat this recurrence 2 years after the tumor has come under control? It has recurred after brachytherapy.
Yeah, I think good question. So I think just to give the brief information that plaque brachytherapy for choroidal melanoma has very good, excellent tumor control, close to around 97 to 99%. So the recurrence is very, very less. Yes, particularly in cases if the tumor localization of the plaque placement is not correct while at the primary procedure, I think then there is this risk that one of the edge of the melanoma which was not covered by the plaque, that can show some kind of growth, but it will not be as late as 2 years. Usually you will see the recurrence might be happening close to around 3 to 6 months, where on your serial color fundus photograph, you will see that that edge of the lesion which was not properly covered by the plaque, that might show some kind of lateral growth. And what is the treatment if there is no evidence of systemic metastasis? Yes, so I think in few rare scenarios we do double plaque, or the patient can be posted for re-plaque, particularly the area where we suspect there is a recurrence. But yes, if there is a smaller recurrence, we can do an adjuvant transpupillary thermotherapy if the lesion doesn't have that much of thickness.
And that was the question I was coming to next. So when would you consider a sandwich therapy for a melanoma? That is TTT with the brachytherapy.
So usually we do it for areas where the tumor is involving the posterior pole and one of the edges very close to the optic disc. So in that cases, when you know that your plaque will not be able to cover that edge which is closer to the optic disc, so in that cases we cover the 90% of the tumor with the plaque brachytherapy, and the rest 5 to 10% which is very closer to the optic disc or the parapapillary area, we can do adjuvant transpupillary thermotherapy.
Thank you, Dr. Vishal. There's a question for Dr. Swati. I think Dr. Vishal has partly answered it. So with the non-availability of PDT, what would be the first line of management for choroidal hemangioma close to optic disc and macula with subretinal fluid? So all of us having the same issue, like we don't have PDT, we don't know how do we go about treating that?
Yeah, thank you, Dr. Shanmugam. So I think, yeah, this has become a universal problem for most of the countries now, including India. So I think, as partly answered by Vishal, I think first we have to see how much of subretinal fluid is there, because sometimes it might be that there is just a sliver of subretinal fluid. If that is the case, then I would just go ahead and do anti-VEGFs and see how it responds before jumping on to any other alternate form of treatment. If there is significant fluid that is there, then definitely that just the anti-VEGF may not be sufficient. Then we have to go for alternate forms of treatment. And of course, the other two alternate forms that we have is doing a transpupillary thermotherapy or plaque radiotherapy. That again, based on the thickness of the lesion, I would go for, if it is less than 4 millimeters, I would still prefer to do a transpupillary thermotherapy, and ICG enhanced TTT always helps. Otherwise, if it is a larger tumor, then plaque radiotherapy might be required. One other point may be that if at all, if we are using transpupillary thermotherapy for a lesion which is very close to the fovea, we can do what is called as a fovea sparing TTT. That means you just do not apply the TTT spots close to on the tumor, which is very close to the fovea, but you treat the rest of it so that you do a fovea sparing TTT, thus minimizing the chances of vision loss due to our treatment.
How many minutes post ICG injection would you treat?
About 30 seconds to 45 seconds, I would start the TTT.
To either of you, is there any role of adjuvant systemic beta blockers?
Yeah, I think that's, I was expecting that question to come. I think, yeah, there are anecdotal reports that are there in the literature where they have used systemic beta blockers. But in my personal experience, I haven't seen very good effect. Like I have tried in a couple of patients, especially with diffuse choroidal hemangioma, because diffuse choroidal hemangiomas are slightly difficult to treat with plaque radiotherapy or the focal treatments unless we go for an external beam radiotherapy. I have tried personally, I haven't had much success with beta blockers, but yes, there are reports in the literature where they have shown a good response. I would like to know from others, have you had good response with beta blockers if you have tried? Dr. Shanmugam, have you?
I have not, as you very rightly said, we are not comfortable treating patient only with systemic beta blockers. So it may be in addition, particularly now that like PDT is not available, we do ICG enhanced TTT in addition to the beta blockers. Despite all that, like nothing seems to work as good as a PDT. So there is still some fluid which is always there, I would say. And one other question was tumor necrosis syndrome in melanoma, how would you treat? I think that was an extension of another question which they had asked earlier, in the sense like the tumor, the retinal detachment persists and the tumor is not growing in a melanoma. So how would you treat?
So I think usually what I would suspect is some kind of rec component. I think that is what I will basically look on by a good clinical examination, because if the tumor documentation shows that it is showing regression, I think then the exudative component should also come down with the regression of the tumor. And if that is not coming down, I think then there is a high likelihood there is an underlying rec component, and I think might be putting a buccal or something. I think that would be ideal.
Would you treat the patients post-brachytherapy with anti-VEGF agents on a prophylactic basis for prevention of the radiation in these complications? If so, at what frequency and for how long?
So I think that the trial, I think what is going to happen, I think DRCR is going to conduct a multi-center trial, might be next 6 months. And I think that will answer the question when we should be putting particularly anti-VEGF Avastin injections at 3 months or 6 months. But Shields do, I think, prophylactically intravitreal anti-VEGF injections, particularly at the time of the plaque removal and then at 3 to 6 months. But this is all kind of institutional practice. And once we have the results from the DRCR trial, I think then we will be able to answer this question.
Dr. Swati, is your treatment different, considering that you have been trained by Dr. Sweets and Dr. Vishal? I'm creating a family rift within the family.
Yeah, so I think in the US, I think the practice is slightly different, mainly because they see a lot of melanomas. And melanomas, as such, we are using a higher dose of radiation when compared to that of other choroidal tumors. So mainly with melanomas, of course, as the US, most of the US groups, they do they do the laser photocoagulation is done at 6 weeks and also follow it up with anti-VEGF. But in our practice, it's like there are very few like I would be treating more number of hemangiomas rather than more number of melanomas, because our melanoma load is not so much. And for, melanoma load is there, but the ones that require plaque are very minimal, because most of them come with very large melanomas requiring enucleation. So when we are treating with other choroidal tumors, as such, I think we are using lesser radiation to the tune of just 4,000 to 5,000 centigrade, which has lesser chances of radiation retinopathy changes. So at least in those cases, we are not doing any adjuvant anti-VEGF or laser photocoagulation for that matter. Even melanomas, we as an institutional practice, we are not doing any adjuvant treatment. And because we use ruthenium plaque, and also because in the US, mostly they use the iodine plaques where the radiation complications are slightly higher when compared to that of ruthenium plaque. So that might be a justification why to do that. At least for us, like we use ruthenium plaque, and the radiation retinopathy, I would say, is not too much of a concern at this point of time, and we are not doing any adjuvant treatment. How about you, Dr. Shanmugam? What is your practice pattern?
Yes, I have also been using ruthenium plaque most often. It's not iodine 125, but it depends on the size of the tumor. If it's a larger tumor, the radiation dose has been a little on the higher side, then I would probably think. But think of adding anti-VEGF, but it's not a routine practice of giving once in 4 monthly anti-VEGF. I don't do that. So last question, I think this has been partly answered. Like, what is the cutoff for observation of small choroidal melanoma, I don't think there's a cutoff size. Like Dr. Vishal mentioned, you have to look for the risk factors. And if any risk factors are there and then growth is there, then you start treating small choroidal melanoma. So I think we'll wind up this session on choroidal tumors, and thank Dr. Vishal and Dr. Swati for your wonderful lectures, and Pradeep for initiating the whole session on the choroidal melanoma. Thank you once again for joining us. Thank you. Back to you, Dr. Divyansh.
Thank you, sir.
Thank
Thank you.
Yeah, thank you, sir. Yeah, it was really a good discussion about melanoma and associated diseases. So the next we move on to more complicated diseases, and I invite my senior colleague, Dr. Rajesh sir, to take over as a moderator.
Thank you, Divyansh. First and foremost, it's a great honor to introduce both my teachers. Dr. Mandeep Sabu is a consultant ophthalmic surgeon. He's a medical retina consultant as well as ocular oncologist at the famous Moorfields Hospital. I had a personal chance to interact with them in 2016, where I spent nearly 2 days. He has a varied experience which can be beamed in his publications as well as his practice, right from anter-segment cataract surgery to posterior segment ocular oncology. So I welcome you for this session. Mahesh Shanmugam sir is my mentor, under whom I have practiced nearly for 14 years as of now. So sir heads the Department of Vitreoretina and Ocular Oncology at Sankara Hospital. Thank you, sir. So without wasting much of our time, let us start with the first talk for the session, that is Masquerade Syndrome by my mentor, Mahesh sir.
Good evening, friends. Thank you for being with us on this special day, a day commemorating the World Cancer Day. My heartfelt gratitude to all the speakers in this session for making it a wonderful session. They have agreed to be part of this session on a very short notice, and thank you very much for your brilliant presentations. Masquerades are neoplastic and non-neoplastic diseases that present as intraocular inflammation or as uveitis. And we investigate uveitis in this presentation. They are outside the scope of this lecture, but what we'll be covering are what are the special investigations which we do in situations of masquerades, the ocular investigations, and more importantly, the systemic investigations. Let us start with this example of a young lady presenting with bilateral hypopyon. The differential diagnosis in this young lady would be an endogenous endophthalmitis in the absence of history of trauma, or uveitis such as Behçet's and HLA-B27 associated uveitis which can present with bilateral hypopyon. But then if you look at the hypopyon carefully, it looks a bit different. There is not much of circumcorneal congestion or conjunctival congestion, and there is a high convex border of the hypopyon. The hypopyon itself seems to be composed of large cells. So what are we looking at is leukemic infiltrate presenting as hypopyon bilaterally. Leukemia can involve the vitreous, the retinochoroidal layer, or the optic nerve, and an ultrasound of the eye can pick up these infiltrates. Whenever we are confronted with a patient where we suspect to have leukemic infiltrate of the eye, they should be subject to systemic investigations such as hemato-oncologist review, bone marrow biopsy, and investigation of the blood parameters. Most often, it will be a recurrence of the disease which can be diagnosed by the hemato-oncologist, but sometimes the patient can be in systemic remission, in which case a simple anterior chamber tap like what was shown just now can confirm that it is indeed the leukemia which is involving the eye. Hypopyon in a young child should be looked at with much more caution, and this is a 5-year-old child with history of fall and suspected to have endophthalmitis. A preoperative imaging did not show any mass lesion, and the child was subject to lensectomy and vitrectomy. When we went back to the ultrasound, we did find that there was an extremely tiny mass in the periphery with diffuse retinal thickening. And the MRI also shows the presence of a very tiny mass which can be missed very easily. So it's always imperative to image a child with endophthalmitis to rule out retinoblastoma when they present with a hypopyon and no view of the fundus. A simple anterior chamber tap confirmed that it was indeed retinoblastoma, And we did give an intravitreal melphalan injection when we did the anterior chamber tab, which cleared the vitreous cavity significantly enough. Why was the mass missed in this child despite imaging? Because this child has the rare form of diffuse anterior retinoblastoma, which forms about 1 to 2% of all retinoblastomas. Diffuse anterior retinoblastoma usually is unilateral and involves older children. It's a very small anterior tumor, despite which it tends to see the vitreous ciliary body anterior chamber angle, and it can present with hypopyon and uveitis. So whenever we look at children where a mass lesion cannot be seen, but hypopyon in a reasonably quiet eye, we should rule out diffuse anterior infiltrating retinoblastoma. Moving on to the most common masquerade which we come across in clinical practice, here is a 68-year-old gentleman who presented with bilateral vision loss. And the patient had been on treatment for posterior uveitis in the last 3 years. And what we see is vitreous cells, secondary retinal detachment, and subretinal deposits and vasculitis. And there are these leopard spot-like appearances of subretinal yellow-white deposits with pigment proliferation on the surface. And the other eye, we could see the retina, where you can see the diffuse retinal thickening. Ultrasonography fundus showed diffuse retinochoroidal thickening. In addition to the ocular investigation, most important is to subject this patient to neuroimaging and oncology evaluation, because 80% of patients will develop CNS disease, and 20% have a CNS disease. So this patient, when we subjected him to MRI, did have a CNS. However, in those with primary ocular involvement and no CNS disease, we have to from the diagnosis. So this patient underwent a vitreous biopsy. He actually presented with vasculitis, something like a frosted branch angiitis kind of an appearance. And a low cut vitrectomy is what done so that the high cut rate can macerate the cells. So a low cut vitrectomy and removing the whole vitreous and sending it for cytopathology does help confirm the diagnosis. We can have a syringe fixed to the aspiration port of the vitreous cutter and aspirate the whole vitreous and send it for cytological analysis. And in some situations where there is predominantly a subretinal lesion, we can do a small retinectomy or retinotomy and aspirate the subretinal deposit and send it for a cytological analysis. It's imperative to stop systemic steroids for at least 2 weeks prior to resorting to biopsy, otherwise we are likely to get a negative result. We did confirm an intraocular lymphoma on cytological analysis. More importantly, OCT can help diagnose lymphoma in much earlier stages of the disease. So these are the signs which we look for: discrete pre-RP nodules, irregular retinal pigment epithelium, and more importantly, the subretinal band. The subretinal band is pretty much diagnostic of primary vitreoretinal lymphoma. There can be diffuse vitreous seeds and inner and outer retinal infiltrates as well. So the OCT also helps differentiate between the primary vitreoretinal lymphoma versus the choroidal lymphoma, which is associated with systemic lymphoma between the retinal pigment epithelium and the Bruch's membrane. In contrast, in choroidal lymphoma, it is deep to Bruch's. So whenever we have patients with recalcitrant uveitis, posterior uveitis, where we suspect a lymphoma, an OCT can also help us clinch the diagnosis much before we resort to a biopsy. Let us look at the case of another gentleman, 70-year-old, presenting with scleritis and serious choroidal detachment and exudative retinal detachment. So we suspected him to have posterior scleritis, but on follow-up, you can see the choroid becomes a little irregular and thickened, and the exudative retinal detachment increased. And there were these focal nodules also. Whenever we suspect choroidal metastasis, we ask for history of malignancy or history suggestive of malignancy, such as recent loss of weight and appetite. And choroidal metastasis is primarily from CA lung or gastrointestinal tract in men, and in women from carcinoma of breast, genitourinary tract and lungs. An oncologist evaluation is how we will go about whenever we suspect a patient to have choroidal metastasis. And most important investigation whenever we suspect a choroidal metastasis is to do a PET scan, because a choroidal metastasis indicates they may have disseminated metastasis elsewhere as well, and a PET scan confirms or tells us that it's just a solitary uveal involvement. But if we are not able to identify the site of primary, then we will be forced to resort to a biopsy. Most often we perform a transvitreal 5-needle aspiration biopsy. The equipment which is used is usually a 24-gauge needle connected to a small bit of tubing and a 10 cc syringe. So here we see a patient with an exudative retinal detachment and a mass lesion inferiorly. We're doing a vitrectomy induced posterior vitreous detachment and using a fine needle aspiration biopsy to take a specimen from the mass lesion. So here is another child who had a coronal mass lesion, and here instead of doing a fine needle aspiration biopsy, we are doing retinochoroidal biopsy because the lesion was very atypical and we're not too sure if it will bleed, and we wanted a nice piece of tissue. So following vitrectomy and induction of the posterior vitreous detachment, the area of the biopsy is marked out and the overlying retina is removed, and with a bimanual dissection, the whole thickness of the mass lesion up to the sclera is taken as a one whole chunk. So this was subjected to pathological examination. So whenever we suspect a metastatic lesion and we are not able to identify the primary, a biopsy from the choroid may be necessary. So intraocular metastasis, how do we suspect? So they usually have absent or minimal inflammatory signs, and classic metastasis presents as cream-colored, shallow elevation, multiple lesions in both the eyes and involving the posterior pole. And they have a disproportionate amount of retinal detachment. But in contrast, you can see a solitary choroidal metastasis presenting as a granuloma over the optic nerve head. And here we see a small optic disc metastasis which continued to increase in size, creating a combined central retinal artery and a vein occlusion, which did not resolve to systemic chemotherapy and ultimately resolved with intravitreal chemotherapy and anti-VEGF agents, but the disc had become pale. So here we see a patient presenting with classic neuroretinitis. Optic nerve head melanocytoma, when it outgrows its blood supply, can set up an inflammation within the optic nerve head, or can result in a neuroretinitis, which usually resolves with steroid treatment. To summarize, neoplastic and life-threatening lesions can mimic uveitis. The amount of inflammation may be disproportionately less, and we may have to resort to biopsy to confirm the diagnosis in select situations. And whenever we look at some atypical features in a clinical presentation, we need to definitely rule out masquerade. Thank you very much for your kind attention.
So thank you, sir. It's nearly a mission impossible which has made possible. Sir has included nearly about 16 to 17 cases in his presentation. Thank you for that elaborate talk, sir. Now I call upon Dr. Mandeep Saboo, sir, for his presentation on phacomatosis.
It is a great pleasure to be joining you today on World Cancer Day for the Ocular Oncology Symposium for Postgraduates. I'm going to speak about the Phacomatosis syndromes. The word phacomatosis was described by Jan van der Hove in 1923. He was a Dutch ophthalmologist, and he described the similarities in neurofibromatosis and tuberous sclerosis. But since then, there is no good definition. Often these are called neuro-oculocutaneous syndromes with an autosomal dominant inheritance. There is the presence of multi-organ hamartomas, and these are ectodermal origin tissues that are affected, usually the skin and peripheral and central nervous systems. It's a group of independent syndromes, and there are multiple tumor or tumor-like lesions that might be or might become malignant, and they're multi-organ, including the eye, and often will lead to a cancer disposition. Neurofibromatosis, tuberous sclerosis, and von Hippel-Lindau syndrome fit this definition better than the other two in this group, Sturge-Weber syndrome and Wyburn-Mason syndrome. The advantage that we have in ocular oncology is that we are able to see most of the tumors in the different layers of the eye. So rather than give you a lecture which is each different condition and their manifestations, I tend to do this lecture the other way, and that is to look at the tumor type and then to decide which of those belongs to which syndrome. And the reason for that is that it is very rare for a patient to come and sit in front of you and say, I've got a condition like von Hippel-Lindau. It's normally the other way. Normally you have an ocular finding and then you have to make a diagnosis. So the ones in yellow are the lesions that are associated with the phacomatoses. So retinal capillary hemangioblastomas with von Hippel-Lindau syndrome, astrocytic hamartoma with the tuberous sclerosis complex, and also with neurofibromatosis type 1. The retinal racemose hemangioma with the Wyburn-Mason syndrome, combined hamartoma of the RP and retina with neurofibromatosis type 2, the diffuse type of choroidal hemangioma with Sturge-Weber syndrome, and not part of the definition, but NF type 1 is associated with uveal melanoma. So diffuse choroidal hemangiomas occur in Sturge-Weber syndrome. There's two patients. One has bilateral port wine stain or nevus flammeus, and the fundus features of the diffuse choroidal hemangioma give you an intense red reflex, which is known as the tomato ketchup fundus. So in the bottom panel, the patient's right eye has a more intense red reflex than the left eye, and so that is the eye with the diffuse choroidal hemangioma. The ultrasound findings are a thickened choroid, and there may be areas that are more thickened than others. They often present to us with an exudative retinal detachment or with glaucoma. The nevus flammeus is commonest in the V1 distribution. There may be other vascular abnormalities in the nasal and buccal mucosa. There is ipsilateral meningeal hemangiomatosis, which imparts cortical atrophy, seizures, and developmental delay, and all of these features are congenital. The Sturge-Weber syndrome has an incidence of 1 in 20 to 50,000 live births, no predilection for race or sex. The incidence of diffuse choroidal hemangioma in Sturge-Weber syndrome is about 50%, and it's more common in eyes with the nevus flammeus involving the upper eyelid. The activating mutation is in GNAQ at codon R183, and that's on chromosome 9q. And these mutations result in dysregulation of the MAP kinase pathway. So here's an example. You can see the intense red reflex. There is a retinal detachment. On fluorescein angiography, there is deep hyperfluorescence. And then on ICG angiography, there is intense early uptake, which becomes brighter, and then late washout. And on ultrasound, as I said, all of the choroid is diffusely thickened with some areas that are more thickened than others. How do you treat these? You can observe them if they're not causing any problems. You can laser with photocoagulation. People have tried oral beta blockers to resolve retinal detachments, though that doesn't really work very well in our hands. PDT laser has been tried to regress the hemangioma and resolve the fluid. Anti-VEGF injections are reported to work well in some cases. And then the main treatment is really radiation. We used to do external beam radiotherapy for most of these, but as with retinoblastoma, with decreased use of external beam radiotherapy, so with diffuse choroidal hemangiomas, it is becoming less available. Our primary treatment is plaque radiotherapy to the thickest portion of the hemangioma. And then some eyes do come to enucleation, painful blind eyes with high pressure. If they present to the ophthalmologist first, they should be referred to pediatrics or neurology for full systemic workup. The combined hamartoma of the retina and RPE is a feature of neurofibromatosis. In this fundus photo, you can see a grey retinal mass with ill-defined edges, often involving or near the optic disc. There's epiretinal membrane and glial proliferation. And if a retinal detachment occurs, then you may consider vitrectomy and epiretinal membrane peel. The best way to diagnose these is with an OCT scan that shows disorganization of the entire retina and often the RPE with an epiretinal membrane. With neurofibromatosis type 2, the incidence is 1 in 33 to about 87,000 live births. It's a sporadic mutation in about half the patients. There's a high rate of mosaicism, and it's a congenital autosomal dominant disease caused by inactivating mutations of the Merlin gene on chromosome 22q. Definite neurofibromatosis 2 involves bilateral acoustic neuromas or a positive family history, and any two of the list of other types of tumor, and that includes the combined hamartoma of the RP and retina, though ocular involvement is rare. Probable NF2 has various combinations, and then these patients also need to be referred to pediatrics or neurology, and they will require neuroimaging, and they have a reduced life expectancy due to neoplasms of the central nervous system. Retinal capillary hemangioma, or the more correct term, hemangioblastoma, is associated with von Hippel-Lindau syndrome. And there's two types of these hemangioblastomas: the juxtapapillary type, shown on the left panel, and the peripheral type, shown on the right panel. The treatment for these can be observation. The smaller ones can have laser photocoagulation. Cryotherapy is possible, or photodynamic therapy. Plaque radiotherapy has been used, as well as external beam radiotherapy. And anti-VEGF is given in our center often as sandwich therapy, where we will reduce the fluid with anti-VEGF and then do whatever other treatment is necessary, such as plaque, and then do a further anti-VEGF injection. The diagnostic criteria depend on whether a family member is affected. If there is a family member affected, then all that is required is one retinal capillary hemangioma or other of the lesions listed. And if there is no family member affected, then if you have two or more retinal capillary hemangioblastomas, then that is VHL until proven otherwise. Sometimes you can't see the small hemangioblastomas, and so doing a survey fluorescein angiogram is mandatory for those cases. Our role in these is often as part of screening, where at-risk individuals or those who are affected with other lesions get a fundus check and a physical examination. The ones that are affected will have brain MRIs regularly. They have yearly renal ultrasounds and triennial renal CT and 24-hour urine VMA for pheochromocytoma. And then at-risk relatives will have screening, which finishes at the age of 65 years old. There is reduced life expectancy due to renal cell carcinoma and the metastasis from this, or intracranial vascular tumors. In terms of vision, the outcomes are dependent very much on the location and number of the hemangiomas and the effects on the retina, but no visual impairment reported in up to about 85% of patients. But we all see patients where there is severe vision loss, and we're giving treatment to preserve as much vision as possible. The retinal racemose hemangioma is not actually a tumor. It is an AV malformation in the retina, and it is found in association with ipsilateral CNS AV malformations as part of the Wyburn-Mason syndrome. So this doesn't really fit the definition of phacomatoses very well. It's not one of the syndromes that forms tumors. It's not familial, and it occurs in the 20 to 40-year-old age group. And really, if we discover one of these, they must have extensive neuroimaging. They can't be treated, and usually there's reduced life expectancy from a cerebrovascular accident. The astrocytic hamartoma is classically a white superficial retinal mass that calcifies to form a mulberry-like lesion. The visual symptoms depend on the location. Sometimes there is even vitreous hemorrhage from these. And malignant transformation is rare. Mostly we don't treat them, but sometimes they're the giant type and they can mimic retinoblastoma, and those eyes need to be enucleated. Here are some images of sporadic ones, and you can see some are calcified, some are not, and some are a mixture. On autofluorescence imaging, there's a variable hyper-autofluorescence signal on the background of hypo-autofluorescence. The hyper-autofluorescence signal comes from calcification. On OCT, the lesion is present in the retinal nerve fiber layer of all eyes, and the depth of the lesions varies. And you can often see that moth-eaten type of picture. Some are sporadic, but some are associated with tuberous sclerosis. And here you may see bilateral multifocal retinal astrocytic hamartomas. And the other features of TS are CNS astrocytic hamartomas, cutaneous lesions, as listed, learning difficulty, seizures, and cysts and tumours of other organs. And astrocytic hamartomas have been reported in neurofibromatosis type 1. Tuberous sclerosis is also known as Bournville's disease. The incidence is 1 in 6 to 10,000 live births. It's autosomal dominant, occurring due to a deletion, rearrangement, or inactivating mutation of the TSC or TSC2 genes. These are tumor suppressor genes. The TSC1 gene is on chromosome 9, encoding a protein called hamartin, and the TSC2 gene is on chromosome 16, encoding a protein called tuberin. Neurofibromatosis type 1 is also von Recklinghausen's disease, with a prevalence of 1 in 3,000 of the population. No relationship to gender, race, ethnic group, or geographical area. It is inherited in an autosomal dominant fashion with complete penetrance but extremely variable expressivity. The mutation is of the NF1 gene, and 50% of patients have de novo mutations. It's a tumor suppressor gene located on chromosome 17q11.2. And these are the diagnostic criteria. Any 2 of the extra-ophthalmic or ophthalmic criteria are required. The extra-ophthalmic manifestations are listed, things like cafe au lait spots, and you have to have more than 6, axillary freckling, more than 2 neurofibromas, or more than 1 plexiform neurofibroma, bony lesions that might present to ophthalmologists with pulsatile proptosis from sphenoid wing dysplasia, and they can also get long bone cortex dysplasia, or if there's a first-degree relative with NF type 1. The ophthalmic manifestations include leash nodules, as shown in the photograph, and optic nerve glioma. The other ophthalmic manifestations, and there are many, include neurofibromas and neurolemomas of the eyelids, conjunctiva, cornea, and orbit. You may see thickened corneal, conjunctival, or ciliary nerves, melanocytic and neuronal hamartomas of the trabecular meshwork, uvea, retina, or optic nerve, glaucoma, and there is an association with uveal melanoma. I am very grateful to you for allowing me the opportunity to join your symposium, and I thank you very much for your attention.
Thank you, sir, for that elaborate topics that's covered extensively, completely enumerating all the phacomatosis in a single presentation and extensively. Thanks for that, sir. Thank you. So we'll go for the last talk, and then we'll take up for the question and answers.
Yes, sir. So again, this is my honor and privilege to invite my senior colleague, Dr. Rajesh, who's a consultant at Sankara Eye Hospital, consultant Vitreoretina and Ocular Oncology Services at Sankara Eye Hospital, Bangalore. Yeah. Can we have his presentation?
Good evening, respected teachers and my dear colleagues. The topic for today that's been allotted to me is surgical management of capillary hemangioblastoma. A short note on the history and pathogenesis includes, it's basically a phacomatosis. What I mean by phacomatosis is a congenital or a hereditary disorder of the neuroectoderm. The name VHL disease derives from two prestigious European physicians, the von Hippel and Lindau. It's basically a germline mutation of the VHL gene, which is located in the short arm of chromosome 3, and it follows the two-hit hypothesis. The Knudsen two-hit hypothesis was first predicted, and the commonest tumor which follows this is the retinoblastoma. This is the second in order. The VHL gene codes for the VHL protein, which is basically a tumor suppressor protein. The tumor suppressor protein, along with CUL2, has a role in the ubiquitin-mediated degradation of the intracellular proteins by proteasome. The clinical manifestation of hemangioblastomas depend on the size and location of these tumors. It's basically unilateral in about 42% of the patient, and about 58 of them have bilaterality. The lesions are more commonly found in the periphery, which consists of about 85% of these patients. So the peripheral lesions are usually subtle red hue appearance, but as they grow, they become more nodular and cause vitreous condensation and exudation. So there is a marked dilatation and engorgement of the afferent arterioles and the efferent veins. So this is associated with retinal edema and hard exudates, which is more so precipitates in the macula, causing visual loss. The juxtapapillary lesions or
There's some issue with the video has frozen, Latif.
Yes, sir. I have told him. Yes, sir.
it was handled differently.
Dr. Rajesh can share the video from yours, share the screen and play from yours. Even if it is not playing.
Yeah, I can share, sir.
Sir, I'm going to do it.
You are doing, man. I do it.
It's open. You continue.
Yeah, okay, man. Yeah. So is the voice heard?
Voice is not heard.
Can you start the video, sir?
Yeah, please start.
You have to remove your headphones if you're connected with your headphones.
You're talking to whom?
Divyan, sir.
Is the voice heard now?
Sir, no, sir. Can you just stop it so that I will share?
Yeah, man, you can.
Yeah.
Good evening, respected teachers and my dear colleagues. The topic for today that's been allotted
Can
to
you
me
increase
is
the volume, please?
management of capillary hemangioblastoma. A short note on the history and pathogenesis includes, it's basically a phacomatosis. What I mean by phacomatosis is a congenital or a hereditary disorder of the neuroectoderm. The name VHL disease derives from two prestigious European physicians, the von Hippel and Lindau. It's basically a germline mutation of the VHL gene, which is located in the short arm of chromosome 3, and it follows the two-hit hypothesis. The Knudsen two-hit hypothesis was first predicted, and the commonest tumor which follows this is the retinoblastoma. This is the second in order. The VHL gene codes for the VHL protein, which is basically a tumor suppressor protein. The tumor suppressor protein, along with CUL2, has a role in the ubiquitin-mediated degradation of the intracellular proteins by proteasome. The clinical manifestation of hemangioblastomas depend on the size and location of these tumors. It's basically unilateral in about 42% of the patient, and about 58 of them have bilaterality. The lesions are more commonly found in the periphery, which consists of about 85% of these patients. So the peripheral lesions are usually subtle red hue appearance, but as they grow, they become more nodular and cause vitreous condensation and exudation. So there is a marked dilatation and engorgement of the afferent arterioles and the efferent veins. So this is associated with retinal edema and hard exudates, which is more so precipitates in the macula, causing visual loss. The juxtapapillary lesions, on the other hand, which is present in about a small number of cases, that's about 15%, may present as a pseudopapillary edema to begin with. Retinal and vitreous hemorrhages are also present, but in very rare circumstances, which is less than 3% of these patients. Coming to the subject per se, I'll be dealing with certain scenarios which have the surgical complications of these tumors. The first and foremost is macular edema. Though macular edema is commonly treated in different modalities, and the mainstay of treatment as of today is anti-VEGF, I would like to enumerate one of my patients in which it was handled differently. This patient was a young childbearing age lady who didn't want anti-VEGF injection, knowing all about the complications. So she wanted an alternative form of treatment. So in the limited choices, I went ahead treating this patient with 2 mg of intravitreal triamcinolone acetonide. There was a gross edema and a neurosensory detachment. So, but on post-IVT on the first day itself, it completely subsided with small amount of hard exudate precipitating in the subfoveal region. So this action with the regression of edema persisted for 2 months and 4 months post-injection. Also, the tumor was treated. The tumor was just found inferior temporal to the fovea. So let us look into the second scenario. If there is a long persistent macular edema or a secondary posterior hyaloid which is thickened and causing an ERM, might lead on to a macular hole, as in this patient. So this patient has a macular hole full thickness along with the inferotemporal hemangioblastoma with a thickened posterior hyaloid. So this patient was taken up for the surgical procedure for treating this macular hole was no different as compared to a normal macular hole surgery. Tricot was used to stain the posterior hyaloid to aid in the posterior vitreous detachments. Once the posterior vitreous detachment was done, care was taken not to engage the vitreous on the hemangioblastoma. Truncation was attempted and completed. You could see that I'm right now cutting the vitreous all around the hemangioblastoma without going too very close or engaging the hemangioblastoma in the cutter. The residual cortical vitreous, which was a bit remnant on the macula, was removed. ILM was stained with BBG adequately, and with the help of a end grasping forceps, the ILM was peeled. Since the macular hole was 420 microns in size, so an inverted ILM peel has been attempted. So the ILM was peeled in a centripetal fashion, with the ILM peeled towards the fovea, and multi-layered ILM was deposited onto the macular hole. Once this was achieved, air fluid exchange was done and the patient was advised for proposition. Not to forget, the hemangioblastoma was treated with lead laser. This is one of the other modifications which have engaged in these patients. Diode laser can also be used to treat hemangioblastomas. Post macular hole surgery, this patient did fairly well. She had a type 1 closure with regression of the hemangioblastoma per se. So let us look into the third scenario. whenever a patient with such amount of macular edema and hard exudate presents in the posterior pole, we should always look what is happening in the periphery, like in this patient who had a large solitary hemangioblastoma in the temporal aspect. So the treatment is well known in these patients, which includes cryotherapy to these peripheral lesions. But the problem was, after successful regression of the hemangioblastoma, we could see a atrophic break at the edge of this tumor. So there was a condition in which we had landed up with an iatrogenic complication where the primary treatment of the hemangioblastoma was successful, but it had led to an atrophic break and a retinal detachment. So this had to be taken care of. Since it was a single break, peripherally located and amenable for indentation, a buccal surgery was advised and done. So post buccal surgery, the retina was completely flat. The hard exudates have regressed beautifully from the posterior pole. Let us look into the fourth scenario, which is one of the deadliest complications, but thankfully it's of a lower incidence, is a complication of the previous surgery. So these patients, whenever present with tractional retinal detachment, an attempt to surgery is done, but complications such as breaks can happen, and this leads to complication of recurrent retinal detachment. So one of such scenarios has been presented here. This patient had undergone twice vitreoretinal surgery for its tractional retinal detachment, but had failed with recurrence, and now he had developed dense PVR with multiple breaks in the periphery. So direct surgical intervention of these membranes may not be successful. So I decided to support the base and the breaks with the 240 band. A scleral tunnel was created in each of the quadrant, and a 240 band was passed with a supratemporal tie. So a 279 buccal, sectoral buccal was placed, especially inferiorly because of the extensive PVR. So upon looking inside, there were multiple breaks, superior temporal, inferior, infero-nasal, and lot of uncut peripheral vitreous. So I started up with carefully dissecting the peripheral vitreous, segregating this vitreous from the underlying hemangioblastomas. We could see the huge number of multiple number of hemangioblastomas, one next to the other, stacked one next to the other with dilated blood vessels. Care should be taken that it has to be peeled. At the same time, we have to make sure that breaks are not created. So sometimes we have to sort for bimanual dissection, like in this step where the inferior vitreous is so very adherent and completely pulling the retina, not allowing it to settle properly. So one of the primary care of us is to dissect this vitreous. Better to do bimanually so that the traction on the retina is less and we have adequate control. PFCL can be used to support the peripheral, the posterior vitreous. So once this is done, the peripheral vitreous is seen all through to make sure that wherever there is huge amount of vitreous that needs to be dissected out and made sure that the traction is relieved completely. So after this, the breaks are marked with diathermy and air fluid exchange to see whether the retina flattens out completely, as happening in this case. The residual PFCL has been removed and extensive laser to the hemangioblastomas and the breaks and the peripheral retina wherever it is necessary has been applied and supported and already been supported with the buccal. So this will ensure to a great success of the surgical intervention. Thank you.
Rajesh sir, you're on mute.
Thank you, one and all. Let's go to the discussion part of it. Mahesh sir, there's been a question directed to you. What are the cases that we take in doing a AC tap in a patient with retinoblastoma?
Usually it's not necessary. Most of the time we'll be able to make a clinical diagnosis, but in case we are expected to do, I would do a long track in the cornea so that the needle track is small enough so that the cells don't come out. And as we do as the needle is coming out after doing a paracentesis, we do a cryotherapy at the site of exit and entry as well. And in addition, immediately follow it up with treatment. So it could be either initial chemotherapy, whatever it is, but then like we do that. In addition, what else we do is to suffuse the eye with the distilled water. Distilled water is known to kill the retinoblastoma cells, and sometimes I do inject subconjunctivally as well.
So you had shown 3 variants of doing a biopsy, a choroidal biopsy or a subretinal biopsy. So can you enumerate just like in each condition, when do you want to go transcorneal, when do you want to go transscleral in such conditions? Or is it that it depends upon the proximity to tumor and the way you look at it? Or is it certain specific conditions are which detects that you have to do it in certain way?
For diagnostic purpose, it is usually transvitreal coming from the opposite side, 180 degrees away, and then go to the vitreous cavity into the retina and into the tumor. So that way, and it could be either with indirect ophthalmoscope or with the microscope, the surgical microscope, but it's usually transvitreal. And transscleral, exactly overlaying the tumor, when we would do is if you want to take a biopsy specimen during plaque brachytherapy for genetic analysis of a melanoma. Otherwise, a transscleral is not usually done because we can spread the tumor outside just for a diagnostic purpose if we do. And subretinal biopsy is more of a theoretical thing where there's a retinal attachment and we go subretinal space and go under the retina to take a biopsy. That's again more of theoretical value. Otherwise, transvitreal is what I would do for a diagnostic purpose.
Thank you, sir. Mandip Sagu, sir, welcome again. Just a few questions that's been posed to you. So one of them is, Pradeep, I think you have already answered him. So if you have an incidental astrocytoma, astrocytic hamartoma adjacent to a disc in a patient who is known retinitis pigmentosa, there's been reports saying that it's not associated with tuberous sclerosis. What would you do? Would you go ahead with trying to diagnose it or further evaluating him systemically, or you'll just leave it at that?
I think in a young patient, I probably would just get a workup done. I'd get a physician to have a look and just make sure that there's no dual pathology. But yes, they can occur in retinitis pigmentosa. But in a young patient, I'd probably just want to get a checkup done.
Okay, sir. Divyansh has asked another question. He says that if we have a wide field OCTA, which you might be having at clinic, or if we have a montage of multiple 15 mm scans, would you recommend that for an initial screening of a patient where you have suspected subclinical hemangioblastomas, or you want to go to FFA itself? Yeah, so I think with better imaging, wide field imaging, I think that's probably good enough. But there are certain instances where angiography is still better than the newer modalities. So, Professor Bird used to teach us when I was a resident that, in a suspected VHL or familial case, and you're screening them, if you see a patient with an epiretinal membrane, then do a fluorescein, and in the periphery, you might see a tiny hemangioma that you just can't see clinically. So I think there's still a role for survey fluoresceins or wide angle fluorescein, but I agree the new modalities are probably going to supersede that. So I just presented one of the cases in which a childbearing age lady didn't want an anti-VEGF injection. So by all of a fluke, that was the only option that was left over. I gave IVT and didn't anticipate it to drain off so quickly. What's your thought on it, or do you have any certain similar experience?
Yeah. Sure. So, it's a great case. We haven't used IVTA in VHL. I think probably what we would do is, if she's not currently pregnant, we would probably do plaque brachytherapy if the tumor is peripheral enough. So that tends to be our second line for, larger hemangiomas where there's quite a lot of exudation. But yeah, the vitreoretinal approach is good. And sometimes, all the approaches, plaque or, anti-VEGF injections, they all fail in these cases. They get terrible tractional detachments and so on. And then really you do need the vitreoretinal surgeons to go in and help with that. So yeah, definitely worth, it was a great case.
Thank you, sir. Mahesh, one of the questions that has been posed in my cases was the second, where I did a buccal. We did a cryo for the peripheral lesion. I had presumed that it is a solitary hemangioblastoma. Pradeep has posed a question that can it be a VPTR? Is it really Hemangioblastoma, or is it a VPTR? What do you think, sir?
If I remember it, that patient did have dilated feeder vessels and a distinct dilated feeder arteriole and feeder venue. So VPTR can also have them, but the distinct dilated vessels along with that the tumefaction, which is very clear. So probably it's a hemangioblastoma.
So what would be your limitation in treating these lesions with cryo? Obviously, you have been treating nowadays larger tumors with plaque therapy. I think Mandeep sir will also agree on the same, because he does a lot of plaque therapy for such patients. What would be your cutoff, sir? Because that was an iatrogenic complication. I ended up treating the hemangioblastoma, but created another problem. So though it was somehow managed, but that's not the scenario. If you have a break in hemangioblastomas, it's always a gone case. So what would you do, sir? In which size of the tumors would you like to do plaque, or would you consider cryotherapy itself?
It's addressed to me?
Yes, sir.
Yeah, okay. See, there are the earlier books of Dr. Shields describes the angioblastoma to have two forms. One is the vitreoretinal form. There is the vitreous, which is overlying it, which is contracted and seem to pulling it up. So you do have this scarring overlying the tumor, which is the vitreous scarring. In that situation, doing a cryotherapy is like aggravating the vitreous retraction and like increasing the chance of a TRD or a break. So just a angioma which is sitting there on the retina with just a little bit of subretinal fluid without overlying vitreous exudation is the ones which probably respond best to cryotherapy, and the risk of complications are lesser. But once the vitreous is involved, then I would agree with Dr. Sagu. I'll probably go ahead and do a plaque brachytherapy on that.
Sir, your take, sir? Mandeep, sir?
I agree completely. And I think the ones where you can do cryotherapy, it is often worth giving sandwich therapy. So give anti-VEGF first, then do the plaque a week or two afterwards, then 4 weeks later, give another anti-VEGF. That reduces that fluid around the tumor and makes the plaque more effective, I think. Another thing that sometimes occurs in these hemangiomas is they get a bit of dystrophic calcification in them. And you can either see that clinically or on a B scan, there's a little calcified area. And then I think the chances of getting a small hole causing a regmatogenous detachment is probably a little bit more, though I didn't see that in your case.
The other thing is like the more posteriorly located hemangioblastomas, I have tried about 3 patients with multiple tumors with diode laser. Diode laser was described for these lesions way back by Shields group in about 6 cases, and they said that it really didn't respond. What I felt was that the lesions were pretty much larger in which they had tried, but these tumors which I had showed the macular hole was much smaller and they responded beautifully. What's your take on that, sir? Anything that you want to, because color doesn't match, the red color shouldn't get absorbed, but despite that it responded very well.
Yeah, for that reason, I haven't used really diode laser for this. I tend to use argon for the small ones. Larger ones, either cryotherapy, although that tends to be relatively few cases. And then in our center, we tend to do plaques for them. So I don't have any experience of that, but be interested to see your results.
Thank you, sir. I still remember when you showed me one of the ciliary body melanoma and you asked, what would you do? I said, like back home, my mentor would do a resection, and you said, no, you can do a surface on the cornea plaque therapy, and you showed wonderful regression in cases. Thanks for that, sir. I mean, that was an enlightening way back in 2016. Thank you.
Pleasure.
So anything else, sir?
I have got one question to Mahesh. Comment, please. Can I?
Yes, sir. Sure.
Please, sir.
So I'm in 35 years in practice in intraocular tumor and uveitis, and I'm seeing increasing number of primary vitreoretinal lymphoma. Is it only due to increased recognition, or do you think that there are certain other factors which made us to have a large number of primary vitreoretinal lymphoma, which are seeing almost like a month 1 or 2 cases? So, what would be the cause why you are seeing so many primary vitreoretinal lymphoma?
Sir, like you have been our teacher, like we have learned from you. So I really don't have an answer to say that like why we are seeing more. Probably it's all of the factors in addition to identification, because I don't think it's just an identification. So probably There are other risk factors which are going on, which are probably increasing the incidence. But if you were to ask me to name them, I really don't have an answer. I don't know if Dr. Mandeep has any answers to that.
No, exactly the same. We're seeing more and more, and I think it is better recognition. Plus also, I think the incidence is increasing worldwide. So, yeah. But it's not clear why that is. I don't think anybody really knows.
So one other question that has been asked, I think both of you, sir, you can put your thoughts on it. Dr. Raman Kumar says that if you have, a systemically metastasized tumor and you have ocular metastasis also, so what would you do? Do you give any kind of a palliative care, treating the tumor per se or the symptoms, or you will just leave it as such because the patient is already on the downslope? Whether you just leave it as such, or you give symptomatic palliative treatment, or a treatment you just treat the metastasis in the eye.
Is this for me?
Yes, sir.
Yeah.
Okay.
Yeah, I think our role in that is in that scenario, and we sometimes do see that, sadly, comfortable for as long as possible, and also for as long as possible. I've had patients like that where, with widespread metastasis, no further treatment, palliation, and the only thing the patient wanted to do was to be able to see her relatives in Australia, one visit, and then to come back, and essentially then she passed away. So that kind of scenario. And I've given anti-VEGF in those situations to reduce fluid. I have also done PDT. Now I know we have currently a problem getting PDT, the Visudyne. But PDT works very well. They come in just for one treatment rather than have lots of external beam radiotherapy. It can be done in the eye hospital rather than in the general hospital. And so PDT does regress metastasis quite well, good local treatment. You can use plaque, but then it's an invasive procedure where they have to be an inpatient and so on. So I think mainly I would just try to control symptoms and give them the best quality of life during their final months, really.
Thank you for that, sir. Mahesh, sir, there's one thing that's been asked. See, you had suspected retinoblastoma in that kid. So what made you think out of the box? And is it that every end of child that we meet, should we suspect something else? And what are the investigation would prompt you to look into that manner, sir?
Every end of child which is presenting to us should at least undergo an ultrasound examination unless we are able to see the fundus details completely, and if there is definitely a penetrating injury. So most of the time it's just a history of a fall from the cycle and things like that, which is not exactly a penetrating injury. But of course, in a child, a penetrating injury can also be masked. So if you're not able to see the fundus in an infant, best would be to image. And if you are not too sure if there is a masked lesion on the ultrasound, best is to have a MRI scan before we go ahead intervening into the eye. So that's what I was trying to say. But if there's an obvious history of a penetrating injury, you can see the site of the trauma inside the eye, still you would do an ultrasound at least to rule out to rule out something else masquerading as endophthalmitis.
Thank you for that, sir. I don't think so there's any other questions. I still, Mandeep sir, I really thank you, because it opens up a wide field. When we interact with people out for different perspective. I still remember the way you showed across certain ultrasonography where there was, blood communications of a melanoma going outside the eye, transclerally, which we couldn't really make it out on the MRI too. So a different perspective we do get when we interact with teachers like you. I thank you a lot for joining us so early in the morning and being a part of this session. I give it back to Dr. Divyansh. Kindly take over and please do the next.
Yeah, thank you. It's been a real honor to be here and to join such a distinguished panel. Thank you very much.
Thank you, Dr. Sajid.
Okay, so thank you again, and it was an exhaustive day for all of us, having a lot of sessions starting from morning, afternoon, evening.
We learned a lot now.
Yeah, so yeah, and then along with that we learned a lot, and so the roots of all goodness lies in soil of appreciation, a quote by Dalai Lama. So at this very end of penultimate session of ocular oncology for postgraduates and World Cancer Day initiative, to close the gap, which is the theme of this year's World Cancer Day. I would like to take this opportunity to thank all my colleagues at Sankara SAV or Sankara Academy of Vision, my head of the department, Dr. Mahesh sir, who gave me the opportunity to be a part of this webinar. Our Dean SAV, Dr. Saptagirish sir, our medical director, Dr. Kaushik Murli sir, and our invited national and international faculty like Dr. Mandeep Sagu sir and Dr. Victoria, who took their time out from their busy schedule. And I really like to thank all of our speakers for taking time out and making immense efforts to prepare and deliver the fantastic and mesmerizing talks in such a short notice. I'm really thankful because it was just 2 weeks we had called, and then all of our speakers on the first go itself, they have accepted the invite. I'm again thankful to all our speakers. Thank you, Dr. Vidya, the curator for the whole ocular oncology webinar. Our tech team support, Dr. Tejaswini, Mr. Latif, Mr. Vivek, our fellows, Dr. Shweta, Dr. Surabhi, and our postgraduates, Dr. Riya, Dr. Kritika, Dr. Sheena. Last but not the least, our viewers and attendees on various platforms for whom the whole webinar was planned and beamed live. Thank you again, and adios, good night, stay safe, take care, and until we meet again. Thank you.
Thank you, Mahesh. Thank you, Dibansh.
Thank you, sir. Thank you.
Thank you, sir. Thank you, everyone. Good night.
Thank you. Thank you, everyone. Thanks, Dibansh. Wonderful lecture.
Thank you, Vishal sir. Yeah, thank you. Okay, bye. Thank you.